My name is Julie Lam, a New York-based writer and artist, a mom of a college-age son. As MaskTogetherAmerica's founder, I welcome all of you to Brace for COVID-19 Wave 2024 with Love, an expert forum our team put together to address the ongoing pandemic. Based on CDC's wastewater monitoring reports for COVID-19, the United States is in the second largest wave since the start of the pandemic. The CDC reported that the viral activity for COVID is very high nationwide between August 26 to January 6 for 20 weeks in a row. The US lost over 1,000 Americans to COVID weekly. In December, we lost 8,569 individuals based on CDC's data. The death toll is rising, while millions of people are getting COVID every day in the US, and tens of thousands of people are becoming long haulers. Mask Together America was initiated in 2020. We are a volunteer organization created to support public health and people who do not want to get COVID, especially those who are immunocompromised and at high risk of serious outcomes from COVID, including myself. Our grassroots awareness campaign is a massive project put together and supported by people from all walks of life across the US. As Dr. Martin Luther King said, "If I cannot do great things, I can do small things in a great way." As an immunocompromised person, I have been taking crash courses on public health, though my ability is limited with a background in creative and communication. I believe I can contribute and help end this mass disabling global event. This pandemic is humbling all of us, showing us the need to work and learn together. We are students and teachers. We learn so we can spread accurate information and help others. How to measure COVID-19 risk. That's the topic we have chosen for our first webinar tonight. We are honored to have Dr. Michael Hoerger from Tulane University as our guest speaker tonight. Before we start, I want to introduce you to our coordinator, Lindsay. Lindsay Schwartz is a COVID survivor and daughter who lost her beloved father to COVID in August of 2020 during the second wave in the South. Lindsay's father was a cardiologist and also beloved grandfather. Lindsay and her children's lives have never been the same since losing him the way they lost him. Since then, she has advocated for vaccination and avoiding complacency. Lindsay joined Mask Together America in 2021 and worked tirelessly to support our educational platform, besides caring for her family. Mitigation is about love, survival, and community. Lindsay and everyone who supports mitigation are heroes to the high-risk community. Without further ado, I want to pass the mic to Lindsay, who will introduce our guest speaker, Dr. Michael Hoerger.
Thank you very much, Julie. Dr. Michael Hoerger is Associate Professor of Psychology, Psychiatry, and Oncology, and Director of the Health Psychology Doctoral Program at Tulane University. He is an international expert in psychosocial oncology as well as pandemic mitigation. Dr. Hoerger oversees many projects noted on the Pandemic Mitigation Collaborative, PMC, website, which is pmc19.com. He is also a founding member of the Global Immunocompromised Health Coalition. Dr. Hoerger, we want to thank you for being here today. And if it's okay with you, we will move on to the questions that have come from our members. And after that, if there's time, we will keep track of some of the questions asked in the chat, and we'll try to get those answered by you as well. Does that work?
That sounds great. I encourage people to drop questions in the chat.
The first question for you, Dr. Hoerger, is how do you feel that people can measure their risk for COVID-19?
Thank you. Pleasure to be here today. And thanks everybody for joining in. Again, please drop questions in the chat. I think there's two main sorts of risks that people focus on. So one is what is going on in terms of transmission in the US or where they live in particular. And then the other is more of an individualized assessment. So in terms of the national picture, the environment of transmission, we know we're in the second largest surge of the pandemic in the US. We are on the back end of the surge. It probably peaked just under a month ago, but transmission remains very, very high today. And it will be a while before transmission is low. And when transmission is low, it will still be quite high in any sort of objective sense, even if it's relatively low compared to right now. So that's all very troubling. In terms of individual risk assessment, we know that there are certain factors that probabilistically put people at higher risk of a more serious acute infection or serious longer term outcomes. But that's all probability, and anyone can have a serious outcome from an acute infection, even if it's a mild infection. So with high transmission, with a lot of people having a known vulnerability and with people having unknown vulnerabilities, I think the best thing people can do is continue to take COVID very seriously and use multi-layered mitigation.
Yeah, thank you. CDC has a COVID tracker and a wastewater dashboard. Which one provides data that people in the US need? And I have another question on the same subject following that.
Sure. So that's great. The CDC is continuing to track wastewater levels. There are all sorts of different wastewater trackers out there. For the national picture, I mostly use BioBot. BioBot had an agreement with the CDC that recently ended, but I did some analyses comparing BioBot to other trackers and was more satisfied with the validity of the BioBot tracker. So that's what I'm continuing to use for now. The nice thing about the CDC data is there's a greater chance that people can get data on what's happening in their own county locally. So for example, here in New Orleans, we have not had great wastewater tracking throughout much of the pandemic, but in, I think, early December, the CDC brought on 2 wastewater trackers locally. So people may be able to get at more granular data, but there may be mechanisms outside of the CDC or outside of BioBot where people are getting local data too. In general, I focus on the national numbers because if you know nationally we're in the second largest surge, that means there's a likelihood that it's going to hit your community at some point. It might not, but it probably will. And so even if you don't have good local data, knowing the national picture is really helpful. If you can find local data, that can be useful too.
Okay, well, thank you. My next question was going to be, how does BioBot and CDC compare to each other? So you already did that. So thank you very much.
One point I'll add is,
Yeah,
even though I prefer BioBot for the national picture, the CDC tracker is still really good for examining shorter term changes. So if you're comparing the state of the pandemic now versus 6 or 9 months ago, that's great. But if you're trying to make longer term projections, you'll see that some of their data, I think to most people pretty obviously aren't as good, where it makes the original Omicron BA.1 wave look a lot smaller than what most people believe based on BioBot and Walgreens and other sorts of data.
well, I don't know a lot about wastewater monitoring. If I could just ask you, are they really only able to do that in urban areas with a high concentration of people, or can they do it for someone in a small town in Georgia?
That's a great question. Looking at the counties that are covered, it is mostly urban areas, but there is a pretty broad range of counties covered. So if people haven't looked up these data, I would encourage them to do so. And even if your particular area isn't covered, you might find that there are 2 or 3 nearby counties that are, and that could give you a better sense of what's going on locally.
Yes, I agree. Okay. Thank you. What precautions should people take in this ongoing pandemic?
People should be doing the effective precautions they were taking during other surges. So people should be taking this very seriously. And we have better knowledge. Most of us have better knowledge than we did early on in the pandemic. And we also have vaccines available that we didn't have early on in the pandemic. First of all, everyone who is able to should get the updated vaccine, and not everyone is able to, but many people are and have not gotten it. I think the current estimate is about 21% of people in the US have gotten it, And that number could obviously be a lot higher because there are a lot of people for whom the vaccine's indicated and who are eligible, which is most people over 6 months old. And so to me, that's step number one. If you know somebody who just hasn't gotten around to it, that would be something I would prompt them with. But there's all sorts of approaches. The key is multi-layered mitigation. And so you've all seen the Swiss cheese model. I can walk you through my perspective of it. The things that we should have in place that we don't have much of right now are financial support. And so there's not a lot of free PCR testing going on. There's not, paid sick leave for a lot of people.
Right.
Really basic issues like that. We have pretty good monitoring of the current state of the pandemic in terms of transmission. A lot of people are concerned that we're not using testing-based statistics, that we're basing a lot of our assumptions on wastewater, but I don't have any problem with that, and wastewater has some advantages. Some things that people should be doing that they might not be thinking about right now are to use contact reduction. And so if you just think about in the course of a year, when you're more likely to gather with other people, try to reduce gatherings during this time of year when there's surges, because a lot of transmission was happening as a result of holiday travel and people seeing families. Other things people can do, continue to use testing. There's often a lot of discussion about, do rapid tests work? Rapid tests are better for detecting high levels of infectiousness than they are for detecting casehood when somebody has a very low level of infection. So continue to use rapid testing before gatherings, follow guidelines for quarantine and isolation, hold things remotely if possible. My group does just about everything we can remotely, which isn't everything. We do have in-person activities for things like meeting with patients, but a lot of activities can be remote. People should be wearing high-quality, well-fitting masks, and if people are not using N95s, I would encourage them to start using N95s if that's something that they can afford. N95s can often be reused many times, and so they're less expensive than the sticker price if people are imagining just using them once and throwing them out. If people have not done any DIY fit testing, I encourage them to do that, because people might think that the mask they have is protecting them really well, but they could have a gap they didn't realize, or they might have a really good mask, but they might not be wearing it very well. And so they might have some gaps at the chin or around the nose, and fit testing can help to improve with that. We could talk a lot about cleaning indoor air. That basically mitigates against the risk, a false negative on a rapid test or mask gaps or that sort of thing, where if virus does get in the air, you can help clean it out of the air faster. Those are the main things in terms of avoiding infections. Once people get infected, they should ask their physician if they're eligible for particular treatments like Paxlovid. And obviously there's been a lot of discussion, especially the past week, about the need to rally around better treatments for long COVID. So that's my big picture take on multi-layered mitigation, and I hope people will have follow-up questions about those components.
Yes, and I found that getting the right fit for my children was especially important. We had to try several different kinds of masks and spend money on it, and that was just what we had to do. And also about air quality in my children's school. My children talked about how the teachers would open the window to the outside, but because of security measures that are unfortunately necessary in school these days, they can only open them a tiny bit. So that's just where my mind went. Thank you very much for answering that question. Who do you feel is at high risk of severe sickness from COVID?
Yeah, that's a great question. To me, it's there are certain risk factors that probabilistically place people at higher risk that are known and identified. Examples would be if somebody is immunocompromised or immunosuppressed, if somebody has cancer, if somebody has multimorbidity, multiple chronic conditions, if somebody is older, if someone is very young, especially infants. So those are some of the known risk factors. You can look on the CDC website for lists of risk factors. One of the studies we did showed that even ever having smoked a cigarette was a risk factor of worse outcomes from COVID. So there's all sorts of risk factors. And if you were to look through it, you would find that the majority of people in the US have some risk factor. But I would say immunocompromised, older adults with multimorbidity, cancer, very young children, infants, those are some of the top of known vulnerabilities, but it could happen to anyone. And somebody could have a health condition that hasn't been diagnosed and they get COVID and they have a very bad outcome. Or maybe there isn't some known identifiable health condition, at any near point in the future, and somebody has a very bad outcome. So there are knowns and there are unknowns.
How do we keep people that are high risk, in-person workers and students safe from reinfection that could exacerbate their medical conditions and reduce their ability to survive an infection?
Sure. I think most of us know what we could be doing. We could be doing a lot of the steps that I mentioned in terms of multi-layered mitigation. The easiest steps would be to have more remote activities. Just about any job could have some remote component, not all, but the vast majority could have a component that is remote or has some flexibility. And there were papers on that very early in the pandemic that even jobs you might not think could have a remote component could a half day a week or something, and that reduces risk. So remote activities, most places are not doing any sort of vaccine requirements anymore. Most places are not having robust testing programs anymore, but encouraging people to be thoughtful about illness, to quarantine if they've had a known exposure, to isolate if they test positive, to have paid sick leave is extremely helpful. Paid sick leave is not solely important for COVID. It's important for a number of outcomes. One of my colleagues here at Tulane has a paper showing that you're more likely to get cancer screening if you have paid sick leave because it's easier to take the time off from work, right? So advantageous for a number of reasons. One of the main factors that people can control is wearing a high quality, well-fitting mask. And so I would encourage people to take that very seriously. When I am in a public space, I'm always wearing a high quality, well-fitting mask. Right now, I'm not wearing a mask because I'm in my own office in a very isolated area of the building, running a DIY air cleaner at 6 times the rate recommended by ASHRAE. So I know that, and that's how I'm guarding against that risk. It's not 100% mitigation, but I feel confident in that. Air cleaners are something else people can add if that's allowed in their workspace. And so those would be some of my recommendations. I would also encourage people every 4 to 5 months, think outside the box, and maybe you want to be doing something vastly different in life if your daily activities are putting you at a high risk of a very serious illness. And so for students, that means really giving some thought to what they want to be doing with their degree program, short and long term. I started a part-time MBA program about 6 months before the onset of the pandemic, and it was a 3-year program. So the majority of it I did, from the onset of the pandemic forward. And that meant pursuing classes that often had remote options or more flexibility. And that took me in a little bit different path on my degree than what I originally planned. People who are working can consider, do they want to stay in their current job? Can they find something else that is fully remote or has a large remote component in a hybrid position?
Understood. Do you think it makes sense for the public health messaging to only ask high-risk patients to mask up?
No, that's, anti-inclusive, short-sighted, ineffective. We know that, anyone could be vulnerable. They may have an unknown vulnerability, so that just doesn't make sense. The number of people with undiagnosed diabetes or hypertension or all sorts of other conditions is very high in the US and in many countries at any given time. So many people have a health condition that they're just not aware of presently. That could place them at higher risk, but there are other unknown vulnerabilities as well. We know that universal precautions are the most effective approach for a number of reasons. The most basic to me is that the vast majority of people, especially people who are not in this kind of meeting, are going to be less likely to have a really good fitting mask. People may be wearing cloth masks, they may be wearing procedure or surgical masks, they may be wearing an N95 or similar mask. It could be a KN95 that's fake, that doesn't filter at the level it's supposed to. It could just be poorly fitting. So a lot of people, even if they're trying, aren't getting the type of protection that they want. And people have been told it's droplets, that you should be more focused on surfaces. And the airborne nature of spread hasn't really been explained to people very well. So somebody might be wearing a procedure mask and think they're doing a great job of protecting themselves when they're not. So having everybody masking is a much more important sort of policy. The effects of masking are multiplicative. So if somebody who is infected is wearing a mask, that reduces the amount of virus in the air. But if other people are masked too, that reduces the risk of them breathing it in. So you're getting, that multiplicative sort of effect of risk reduction. The other issue is not everyone can mask. Some people have medical conditions that make it impossible to mask. There are any kids under the age of 2, approximately, cannot mask, and children under 6 months cannot get vaccines. So that's a serious issue. That's an issue we've faced a lot during the pandemic. I have twins that are just over 1.5. And so most hospitals are not taking masking very seriously. Either people are wearing procedure masks or cloth masks, or they're not masking at all, or they're masking only in patient areas, which doesn't make any sense because virus travels through the air. So there's a number of people who have unknown vulnerabilities. There's people who cannot mask in general, and then there are people who cannot mask in particular contexts. And so if you go to a dentist, you can't wear a mask during that. If you are dealing with throat cancer, or you are getting evaluated for heartburn and they're examining your throat or something, any number of issues can require demasking. And so having a policy that everyone who can mask should mask protects people who are unable to mask, or protects them when they have to take their mask off for any sort of medical or dental or other important procedure.
Well, and since you were just discussing masking in healthcare settings, can you share any advice for people whose medical providers or doctors won't wear masks upon request?
It's very troubling. I don't think I have any tips that can be universally helpful. It's a situation where people are being oppressed, and there's not a lot that we can do about that as individuals. Sometimes you will hear people recommending just go find a different clinician, go to a different clinic. And in many places, you only have one option.
Yeah, that's true.
Or going somewhere else may mean a 10-month wait or a year wait. And you have discontinuity in care. You may lose your clinician if you're too forceful on these issues. So it's a situation of really people dealing with challenging power dynamics. There's not a lot people can do. People can try submitting complaints to medical centers, and that has some success for some people, but a lot of times that's ineffective as well, and could lead to retaliation. And so it's a very frustrating situation. When my twins were born, that was a situation we were dealing with. It was right at the onset of the BA2 wave, which was the wave that started to rise in May after the large BA1 wave. And people were, at least in inpatient setting, still taking some precautions when they would come into your room, but it was mostly procedure masks or occasionally cloth masks. And one of the challenges we faced was I had 2 HEPA filters plugged in because newborns cannot mask. And so having people with potentially with COVID wearing procedure masks around them is not a very wise situation. And they threatened to unplug our HEPA filters. And so in that situation, my tactic was to force a delay, because I knew we would be out of there in a few days. And so I just tried to get people going up the chain till I could get somebody to talk to me about unplugging these HEPA filters. And for me, delay was the tactic. Other people in inpatient sort of settings, they will put signs on the door requesting that people wear masks or that they wear N95 masks. We did that as well. Nobody took any of the masks, and we did have one clinician take a box of rapid tests with them. So I think it's very individualized. It's very frustrating. It's very oppressive. And it's an issue that all of us are dealing with to some extent, but it's really frustrating for anyone who is having a lot of medical appointments because they're dealing with this all the time.
Well, I think you're trying to protect your infants, and them giving you a hard time is deplorable. But thank you for doing that. I think that's a good idea. If you'll give me a second to share my screen, I want to show people some pictures. So you see the headline: states are trashing troves of masks and pandemic gear as huge, costly stockpiles linger and expire. So the AP found that at least 15 states from Alaska to Vermont have tossed some of their trove of PPE because of expiration, surpluses, and a lack of willing takers. Into the trash went more than 18 million masks, 22 million gowns, 500,000 gloves, and more. I think that's pretty disturbing. And how do you personally feel about state governments trashing expired stockpiles of PPE?
I mean, it's a political strategy. It's not a public health strategy. The public health strategy would be to inform people about transmission and about the seriousness of the illness, and encourage people to wear masks, require masks in public settings, and help people to find the best mask that fits their face. And so that's what we should be doing. We know that for many people, during a surge, or if they're known to have a higher risk, many people are very interested in wearing high quality, well-fitting masks during those contexts. And so if you look around now at people you see who are wearing masks, for me, probably 90% are wearing a procedure mask that's providing very limited protection. And so, you know, a lot of these masks could have been given away. And if people were aware that we're in a surge, or if they were aware of previous waves and surges, a lot of people would have worn masks if they were warned, and if they were encouraged to do so. But our public health infrastructure is not doing a lot to warn people when the situation of transmission is worse, and is not linking wastewater or other data indicating a surge to actionable steps that people should take. The approach is more, we have this wastewater dashboard, good luck.
I see. And one thing I'm wondering is, does this PPE expire to such an extent that it should not be used?
I do
Is
not
there
know.
any justification of throwing it out after a certain amount of time, or can it always help?
I don't know about the gowns and gloves, though I can't imagine those offering a lot of protection against COVID anyway. For masks, what I've heard is that they maintain a lot of their filtration long after the expiration date, but I would suggest talking to somebody who you know, does actual mask testing about that.
Right. Do you have any ideas about what could have been done with that PPE? Where should it have been? Where should it have gone instead of into the trash?
Well, I mean, the pandemic has been going on a long time, so there shouldn't have been this stockpile of 18 million. That could have been given out, you know, over the past several years, and it could have been mailed to people's homes, much like what has happened repeatedly with rapid tests. So that's not a particularly challenging logistical issue of getting masks directly to people. Around here, when masks were being given away for free, it was mostly through retail pharmacy chains. And so in other cities, they've expanded beyond that and have given away masks in many other settings. And so there could have been an expansion on whatever existing protocols people were using locally to make them more available. Yeah, I mean, 18 million masks is not even very many masks, considering there's over 300 million people in the US. So that's really a drop in the bucket if you're
that's true.
to get masks out to people.
That's true. I see what you mean. I mean, when my father got sick and my doctor found out that I got COVID from him, she asked me on the phone, well, were you wearing goggles? And did you have gowns? And I was too stunned at the time to really answer that question. But no, in July of 2020, I did not have access to goggles, and I had 2 surgical masks. So no. So seeing this kind of waste is frustrating, in my opinion. The next question, most people live paycheck to paycheck and can't afford NIOSH approved respirators. What's your recommendation for people who are struggling to stay safe?
Yeah, it's very frustrating. I think about that situation, and if the pandemic were happening 30 years ago as a kid, I would probably be on my 7th COVID infection by now, considering we've had 8 waves, right?
Right.
There's no way my family would have been able to afford just about anything to help with that. And who knows, we might not have gotten vaccines, even though we would have been eligible and it would have been fine for us.
Right.
So yeah, it's very frustrating. I mean, the first piece of Swiss cheese in my mitigation model is financial support. And so if you look at the long-term financial impact of COVID, it's astronomical compared to what we could be spending on prevention. And so that's an obvious public policy and long-term political failing, even if there are short-term political benefits. What people should be aware of, though, is that they can reuse N95s many times as long as they're not damp, they're not soiled, they're not obviously damaged, the straps are not getting loose or starting to tear. So that really cuts down on cost quite a bit. If you're thinking about an N95 costing about $1, but you're able to reuse it 5 times, that's getting it down to about 20 cents. And so that may be something that people can afford. And that's about the pricing in the US of a 3M Aura. If you look at the 3M V-Flex, which comes in 2 sizes, that will fit most people, but not everybody. Those are often substantially cheaper. And there are some other N95s that are duckbill and look definitely more duck-like that get quite inexpensive, more like about 20 cents each, I believe, last I looked. So 20 cents, you wear it 5 times. That is an expense that a lot of people could tolerate. More people can afford that than perhaps they realize, but there hasn't been a lot of guidance on routing people toward N95 masks that will fit most people, that are low cost, and repeatedly reusing them while the straps still hold up. And that's a lot of politics. That's a lot of droplet dogma. If you're imagining COVID transmitting by surfaces, you would never recommend that somebody would reuse an N95, right? Because what if it gets COVID on it and you're touching it and you're keeping this contaminated thing around you all the time? But since we know that's not how the virus transmits in any meaningful sense, that's outdated advice.
Okay. What is your advice for the U.S. government regarding pandemic preparedness? I'm interested in that too.
I don't think my advice is likely to be utilized, except maybe people can make some small policy wins. I'm hopeful that people can do something about this policy in California of people only isolating a day and going back to work or school when they're still testing positive. As I mentioned before, rapid tests are really good for detecting if somebody is highly contagious. And so if you're positive on a rapid test, you are highly contagious and you should not be going to school or work. It's pretty much the worst advice possible. And if people are only isolating for a day, that actually means that they're going back to school or work often right as their level of contagiousness is heading towards its peak. So
Right.
It's probably the worst good faith public health advice I've seen in the pandemic. There are a lot of bad actors. I don't think this was intentionally designed to be bad. I think it was designed out of sympathy for families where having a child home for an extra few days or missing work for a few days is a legitimate struggle, but it's absolutely a policy that's going to lead to infectiousness. So that's an area where I think people might have some room to get some wins. There may be some possibilities in terms of getting the ASHRAE standards for indoor air cleaning enacted into laws. And so I would encourage people who are in states where there is an an interest in enacting scientific standards, that is a possibility. And I know there's some work being done in Canada to try to codify ASHRAE into law. I don't know the status in any particular states or regions in the US, but that would be an area. I think probably what will happen is this will affect politics longer term, because any serious attempt to understand COVID and the pandemic indicates that this is a very large long-term problem, and ignoring it for several years or downplaying or minimizing it for several years is going to exacerbate that problem. It's not going to make it go away.
Understood. How can friends and family of high-risk people support them the best?
That's a great question. I think it's important to check in with people emotionally and acknowledge the stress and oppression that people are facing, that a lot of people who have not dealt with discrimination before in any large sense are now experiencing that. And people who have dealt with discrimination for a long time are now dealing with another layer of discrimination, and that's very stressful. So it's important for families to be emotionally supportive, but it's also important for families to use multi-layered mitigation to the extent possible to help somebody with a known vulnerability. And that would include doing things remotely, rapid testing before seeing each other, wearing high quality, well-fitting masks, doing things outside, upgrading or adding air cleaners, things along those lines, the different components of mitigation. If somebody is eligible and able, getting vaccinated if they haven't gotten that recently. So those are the sorts of things that I consider. A lot of family members are not doing any of that, are not interested in any of that. And so it's also important for individuals who take COVID seriously to set boundaries. And that may be passively reducing interactions with people who are less cautious, or it could be setting very firm boundaries of, we don't do X, Y, and Z, or we don't do X, Y, and Z unless these particular mitigations are in place.
Yes, I agree. Can you comment on comparisons of HIV and COVID infection and the impacts of T cells?
No, I would strongly encourage talking to somebody with more specialized expertise on that. When I was doing my MSCR degree, the most challenging class I had was molecular medicine with lots of other physicians who understood all of that very well. And it was absolutely the most challenging topic for me, where I had to study more than anything. So go talk to the relevant experts on that. What I do think people should be cautious of is when you hear anyone making very bold assertions with certainty in any direction that this is nothing like HIV and there's no data to support that. That would be a problematic statement that to me would be a red flag. At the same time, if you hear somebody expressing with certainty that this is very much like HIV, I would be cautious that they're going beyond the existing evidence. But it's important to consider that scenario as a possibility, and that's why everyone should be cautious. That's the precautionary principle. And when you see these studies starting to add up, where we're seeing these sorts of concerns that people have raised, I think that raises more alarms for me. But we're not going to know the answers to these questions for another 5 years or a decade or longer. So what are people going to do? Pretend that this isn't serious until the meta-analysis of longitudinal studies comes out? I mean, I encourage people to take it seriously, but talk to other experts on that.
Well, I do too, because I remember, there was SARS, there was MERS, and we kind of got lucky that they weren't as respiratorily transmissible as COVID-19 was. But you just hope that eventually we'll learn the lessons. What is your advice for organizers and activists during this pandemic and time of government failure?
I would encourage people to be persistent and take the long view. So we just are going through the second largest surge. But if this is the second largest surge, 2 years after the largest surge, what's going to happen 2 years from now, or 4 years from now? I don't see any indication that we're doing anything to prevent this at a large national or international level. So I think people should consider that we may experience much larger surges in the future. And if somebody doesn't listen to you now, they may listen to you in the future. And unfortunately, it will take some people getting a very bad infection for that to happen. It may take politicians or celebrities having very serious outcomes before people take this more seriously. But if you look at the evidence, the long-term trajectory of what we're doing is not great. And so I encourage people to take the long view on that. I've mentioned in passing to a number of people that leading up to the original Omicron BA.1 surge, the largest surge, I was very forceful locally about improving air cleaning at some of the educational settings, and was completely ignored, in some cases was retaliated against. And you know, probably within 2 months after the BA.1 peak of the surge, places were upgrading their air cleaning because they had just seen the effects of what happens when you're not cleaning the air during a surge. And so that was very tragic for all of the people who got COVID in that context. But to the extent they're still doing air cleaning, that may be a lot fewer infections going forward. And so I encourage people to take that long sort of view, be persistent. My mantra as an activist has been to consider what other people are willing to do and always try to go one step further. And so I encourage people to think in that capacity as well. Do something that you think is 10, 20% outside of your comfort zone. And that will often encourage other people to follow and do the same.
I think that's good advice. Thank you. I think now we have time for a few questions that came from our participants, if that's okay.
Yeah, great.
One question is that they're aware of people using CO2 monitors to assess the environment. How does this work, and does it have value?
Yeah, great question. I can't believe I skipped over that. I use a CO2 monitor. I don't happen to have one on with me, but I assess my workplace pretty regularly. I assess places I go pretty regularly because some places that have great ventilation at one point of the pandemic now have horrible ventilation as maintenance has fallen off a cliff.
Yeah.
And so just because a place has good air quality at one point doesn't mean it does later. I use it in a number of other settings too. But basically a CO2 monitor, there's all different types of air quality monitors, but yes, a CO2 monitor like the AirNet 4 will tell you how many particles per million of CO2 there are in the air. It's indicating how, in general, how much air people have exhaled. And so it's a proxy for COVID risk in a particular setting because it's getting at ventilation. If you've got great ventilation through the HVAC system bringing in outdoor air, or you've got windows open, or you've got doors open, or you're outside, the number is going to be much lower. If there's not good ventilation, the number is higher. It is not affected by filtration, HEPA filters and DIY air cleaners. Those filters do not grasp on to CO2. They're not pulling CO2 out of the air. So it's really an indication of ventilation, how much outdoor air you're bringing in. And if the number on that is very high, that should be concerning to people because it means the situation is not likely being properly ventilated. There are many caveats that building engineers could tell you about this, but in general, I find it a useful proxy. So I use it to identify spaces that I know are higher risk. Sometimes I've used it to identify places I would think are very high risk, but it turns out they actually have excellent ventilation. And so that's a relief. So anyway, it has a lot of uses. I would encourage people to look more into that. Go on Twitter and search for CO2 monitor or AirNet 4 or things like that. And you'll find a lot of helpful information.
Okay, thank you. I'd like to talk a little bit about fit testing since you mentioned that earlier. What is the mask you would most recommend? What kind? And then how do you make sure that fits the best for you?
Right. Yeah, so I recommend for most adults, start with the 3M Aura, AURA, and that will fit most people. There's different versions of it that have different straps that vary in durability. But start with that. That fits most people. Some people it's too big, some people it's too small. I wear that sometimes. I prefer a mask that's a little bit bigger, which is the 3M B Flex. And that's great because it fits me better. It's also a little cheaper. If you need something smaller, my next step, or if you're just not getting quite a good fit on it, try the Vitacore Can 99 or try the B Flex Small. And usually some combination of those four will fit most adults, but not everyone. Some people will have more of a struggle. I often wear a flow mask, which is an elastomeric mask, a mask that's designed to be reusable and seals very well around the face. And if you go on Twitter and you search for me and DIY fit testing, you'll find a thread that goes through some examples. And I also link to other people's threads where they have instructions too, so you can kind of get at least three different perspectives on how to approach fit testing. And it's not very expensive. You would get a nebulizer or a similar product, which just takes something that's liquid and turns it into a spray. And you get some Bitrix fit testing solution, which is just a solution that you can taste. And what happens is you breathe through your mouth while you have your mask on, you spray the solution. If you can taste it, you're getting some kind of leak because it can't go through the filter. It can only go through gaps. And that's telling you you have a gap somewhere. And so I used that to find out which masks work best for me. I used that to find out how many days can I go without shaving before I start to get a really bad fit. And if I know I'm going into a high risk setting, I better shave that day because I don't want to be 3 or 4 days out. I use that to figure out how to get my mask to fit best, and that some of the good masks I was wearing, I was not pulling far enough back under my chin, and that when I did that, I got a better fit. So it can be very practical, and some people are able to find the supplies they need and do this very cheaply. When I did it, I was just kind of rushed searching for what to buy, and I think it was like maybe about 40 or 50 bucks all in for the fit testing solution and the nebulizer, which can be a hardship for people, but also consider if you get this setup, you can use this for your entire family. You can use this to support friends. So it doesn't have to be something that's just for an individual.
Do you have any idea about like nasal washes? And I can't find the exact question right now, so I'm sorry, but is there any kind of efficacy to doing some kind of nasal wash?
Yeah, that's something I get asked a lot about. Nasal washes like neti pots, nasal sprays, mouth washes, things like this. If you look at some of the older products, the FDA has basically told them stop advertising these as anti-COVID products very clearly. And there continue to be more and more products that come out like this. I just saw another one the other day that somebody posted on Twitter where it was like, it reduces your risk of COVID for 8 hours. And just the most blatantly false claims that are completely at odds with procedures for anything the FDA would allow people to say. I looked it up. The FDA hasn't taken any action against them, but it was just so flagrantly bad, no evidence whatsoever, and they're claiming something offers 8 hours of protection. So I would encourage people to be very cautious about that. There are some people that try to talk about, theories of how these physically might offer some benefit. I don't find them compelling at all. I think it's mostly a waste of money. It's companies in the short term trying to make a profit off of individualized advertising to people who are COVID cautious. And I think a lot of them will get banned or told that they can't market their products in a certain way. What I worry about most is that these products actually have negative effectiveness, that what happens is it leads people to let their guard down. And so they think, okay, I've been invited to this work party. I'm going to seem really awkward if I'm the only one there wearing a mask. So I'm going to do nasal spray in advance. And then, surprise, surprise, they get COVID, right? So,
Right.
But anyway, if that's like the most unpopular opinion in the world, if I wanted to, approach getting ratioed, I would say, don't use nasal sprays on Twitter or something like that.
Oh, thank you. Another question is, the fact that most of the population has had COVID now seems to indicate that most people are now immunocompromised. Do you have any thoughts on that?
That's a claim that I think gets close to what I'm talking about in terms of overstatements of saying that most people are immunocompromised, but it depends on how people are defining that. If we wanted to soften that language some to most people could be immunocompromised in ways that we don't yet understand. I think that would be something that I would be, more supportive of. But I would be worried that that's going a bit beyond evidence. That doesn't mean we shouldn't be cautious, though. It's just the evidence isn't there yet. But I'm not going to wait around 10 years to find the evidence. I'm going to be cautious.
Yeah, I understand that. If you haven't, I'm going to try to find one more question from the audience. Julie, do you have any that you particularly wanted answered? I might have missed one that you wanted.
I think we're running out of time. We have
Okay.
another speaker waiting.
Great.
Thank
Dr.
you,
Hoerger, thank
everyone.
you so much for being here.
Yeah, thank you. I really appreciate you hosting this event. I hope it's helpful to people. And there will be a recording that people can watch. And I hope a lot of people will be able to see it. So thank you very much, both of you.
The whole webinar. So we're going to be sharing that on YouTube and also on Instagram and Facebook. So everyone will be able to see whether they are edited short pieces as well as like long formats. And definitely we'll make sure that we share all the information that you give us your precious time to share with us today. Thank you so much, Dr. Hoerger.
Thank you so much.
Hi, everyone. I think we have to, since we're running out of time, we have to move on to the next section right away. And
I think we could take a 2-minute break.
Okay, 2 minutes.
People, yeah.
Yes. Okay. Thank you, Sarah.
I'm going to watch the rest on recording, so I'll go take my children to do something. Make sure they get their homework done. Thanks a lot. Enjoy the rest of it. I appreciate you all.
Thank you.
Hi, Rachel. Thank you for joining us today.
Hi. Thank you for having me. I'm glad to be here.
All right, we are at the top of the hour. Hello, everyone. I'm Sarah Cahill. Thank you to Lindsay Schwartz for moderating the first hour of this webinar. We really appreciate her doing that. I will be your moderator for the next 3 hours. If you have any questions for our panelists, please drop them in the chat. We're keeping a close eye on those, and we want to make sure that we can get to as many of your questions as we can. But first, I will turn it over to Julie Lamb to introduce our speaker. Julie, the floor is yours.
As MaskTogetherAmerica's writer, I welcome all of you to the second webinar of Race for COVID-19 Wave 2024 with Love, an expert forum our team put together to address the ongoing pandemic. Before we start, I want to share my personal journey becoming a long hauler. I got COVID during the winter break of 2021, mistakenly thinking that I can relax after vaccination. A family member who didn't show any symptoms passed it on to me. I had 5 nights of insomnia, breathing difficulty, and cold symptoms. My infection was considered mild, but I was treated with Paxlovid because I have an immune disorder that affects my kidneys. COVID exacerbated my underlying condition. In addition to damaging my kidneys, it triggered Sjogren's syndrome and sleep apnea. It took 2 years to get a diagnosis of the shooting pain in my eyes that made me unable to drive. Really tough to be a photographer. My primary physician sent me to see over a dozen specialists. So I was in and out of doctor's offices for 2 years, not knowing what's wrong with me. The doctor I saw didn't know how to treat me. A pulmonary doctor even said that he doesn't understand long COVID. In the last 4 years, I have interviewed hundreds of long haulers and shared their stories on MaskTogetherAmerica's platform. My connection with fellow COVID survivors helped me get through my struggles. While a diagnostic process was despairing, I found strength to carry on, knowing that people who care do exist. COVID-19 is not done with us. Repeating infection increases the chance of long COVID. COVID can trigger the development of POTS in some. What is POTS? Is the topic of our third webinar tonight. And we are very honored to have founder of Awareness for POTSies, Rachel Hellman, as our guest speaker tonight. Before we start, I'm pleased to introduce Sarah Cahill, the coordinator for MaskTogetherAmerica. When she has helped us organize over the past 2 years. By profession, Sarah is a certified public accountant, CPA, utilizing her expertise in numbers and statistics to gain comprehensive insights into the dynamics of COVID-19 pandemic. Her commitment to understanding the pandemic is deeply personal, driven by the fact that her husband possesses 3 risk factors for severe disease. From the onset of the pandemic, Sarah has taken a conscientious approach, recognizing the potential risks associated with the virus. Her steadfast belief, universality of vulnerability, emphasizing that everyone shares a vascular system, underscores her commitment to fostering a collective awareness. Despite the challenges, Sarah has been privileged to remain COVID-free, attributed to this to the ability to work from home and the diligent use of N95 respirators. Without further ado, I would like to pass the mic to Sarah so she can introduce our guest speaker.
Rachel Hellman is a PMHNP DNP student at GW and is the founder and president of Awareness for POTSies at Awareness for POTSies, which is a 501c3 nonprofit organization dedicated to providing the POTS and chronic illness community with support, empowerment, and compassion. As a patient, Rachel knows how difficult living with a diagnosis like POTS is, as she also battles ME and CFS with POTS and mast cell activation syndrome, MCAS. After her training as a psychiatric nurse practitioner in a doctoral program, she looks forward to further supporting the POTS and chronic illness community with their mental health while passionately advocating for what they deserve. Rachel developed POTS in 2019, but was dismissed and misdiagnosed for almost 2 years, experiencing medical gaslighting and medical trauma. She wants to ensure that future patients do not suffer as she did during her journey and instead feel loved, supported, believed, and heard by their medical teams. So thank you so much for being here, Rachel. Really amazing journey that you've been on so far. So I really appreciate you being here to share your expertise and your time with us. We wanted to get things kicked off kind of by discussing, like, what does POTS stand for and what is it? What are some of the symptoms and daily things that a POTSie would face?
Yeah, I think that's a really important first question. It's hard to talk about POTS if we don't first talk about, what it is and what it stands for and some of the other critical components. So POTS is a form of dysautonomia, which refers to malfunctioning of the autonomic nervous system, which is a part of the peripheral nervous system. So it controls a lot of things in our body that we don't have to think about normally. So physiologic processes that involve the cardiovascular system, the respiratory system, the digestive tract, the reproductive system, urinary system. So in that, POTS is a syndrome. So it stands for postural orthostatic tachycardia syndrome. And one thing that's a little difficult for a lot of providers when treating individuals with POTS or seeing individuals with POTS is remembering that POTS is a syndrome. So there are usually a group of symptoms that are consistently seen and occurring together in individuals with POTS, but you can have mild forms of POTS, moderate forms of POTS, or more severe forms of POTS. And despite standing for postural orthostatic tachycardia syndrome, which can seem misleading in that a lot of providers may think to themselves, or even individuals, may think to themselves, oh, I think the predominant symptom is tachycardia. That's not the case. So because, again, if we go back to the fact that it's a form of dysautonomia affecting the autonomic nervous system, and remembering how many different parts of the body that impacts, it's common for individuals with POTS to present with 20 to 30 symptoms, sometimes more. And that can seem alarming, but it's actually understandable if we think about the autonomic nervous system. So I think, so what is POTS? What does POTS stand for? And then what was the other piece? Just so I make sure I touch on everything.
Sorry, my unmute button was
it's okay.
hiding there. Just looking at what are some of the symptoms that you might experience on a daily basis?
Okay, so individuals may experience heart rate changes, which can include tachycardia, fast heart rate. They may experience palpitations. They may experience changes in their blood pressure. They may see blood pooling. So when they go from a position from sitting to standing, or sometimes even lying to sitting, they may see that when their legs are dangling or down, they notice their feet or their legs are turning red or purple. This can also be seen if their arms are dangling. You put one arm up and one arm down, and then you compare the two. You can see that the arm that was down will be darker than the arm that was up. And a lot of that has to do with significant blood pooling. Now, it can be more difficult to recognize blood pooling depending on race, and that's another barrier to seeing this sign. So it's not fully visible in everyone, but blood pooling can occur in the abdomen, and it can also occur in the lower extremities. Other symptoms may include urinary symptoms like urinary urgency or frequency, sweating challenges, so either not sweating at all or sweating too much, brain fog, which I struggle with as I'm thinking about all of the symptoms. Brain fog, shortness of breath, chest pain, nausea, vomiting, diarrhea, constipation, difficulty. Again, we talked about sweating. So some individuals may struggle with heat intolerance or cold intolerance. So again, there are many different symptoms that individuals may experience. And alongside POTS, there are other conditions that, and fatigue. I want to emphasize fatigue as well. But there are other conditions that individuals may have in addition to POTS that can mimic POTS or may exaggerate symptoms that individuals are experiencing. So that's really important to consider too.
Thank you. Actually sounds like a lot of overlap between symptoms of POTS and symptoms that long haulers experience. So I can see how there could be a connection there, which leads into the next question. How are POTS and COVID infections related? Will everyone who gets COVID end up developing POTS?
Unfortunately, POTS and COVID infections are very related. Prior to the COVID-19 pandemic, around 50% of POTS cases were linked to viral infection triggers. That doesn't include all individuals who have POTS. Other triggers can include bacterial infection. So we do see POTS with individuals who have Lyme disease. We see POTS after pregnancy. We see POTS after significant traumas, concussions. Unfortunately, we also see development of POTS after vaccination. So really, what we're looking at are immunological stressors, and we know that COVID infections are significant in terms of how they affect the body, how they stress the body, stress the immune system. So right now, around 1 in 8 people they're estimating are developing long COVID after a COVID infection. And in the last few years, they've estimated that around 67% of individuals with long COVID were developing dysautonomia. And one of the more common forms of dysautonomia that we're seeing in individuals with, under the long COVID umbrella is POTS. So they're very much related. But it's important to note that other conditions that are being seen post-COVID, like mast cell activation syndrome, ME/CFS, these also have fatigue components, and individuals with mast cell activation syndrome can have tachycardia, they can have palpitations. And so it's really important to look at all of the other potential conditions that individuals may be experiencing and presenting with, and making sure that providers are considering all of them and screening individuals for all of them. So again, very much related, has to do with the fact that COVID, in our view, is an immunological stressor, and all people who get COVID will not necessarily develop POTS. But again, we know that reinfections increase risk of long COVID. And I would assume, I can't know for sure, I would assume that with each reinfection, we're increasing risk. And there are certain groups of individuals who are at higher risk. So individuals assigned a female gender at birth are at a higher risk. Individuals who are younger are at higher risk, similar to what we see with autoimmune conditions, because there is believed to be an autoimmune component for some with POTS. So it's really important, in my opinion, to recognize this. And I don't believe that anyone can confidently say that they're never going to develop POTS. But I do think that there are individuals who know and understand they are also at higher risk.
Zena in the chat wanted to know if there's an association with POTS and with reactivation of Epstein-Barr virus, BEBV.
Yes.
Okay.
So that's a great question. And one thing that we've noticed is that a COVID infection may not have been your only trigger. You may have a history of childhood trauma, which we know is also an immunological stressor and a stressor in the body. You may have a history of Epstein-Barr virus. You may have a history of having, influenza. And perhaps it's all of these triggers together that are increasing risk, and then, developing a COVID infection. So it's possible that that's the case. It's also possible that individuals who don't have any previous triggers, who providers deem aren't at higher risk, also develop POTS. But yes, absolutely.
Zay in the chat wanted to know, how can you distinguish POTS fatigue from ME/CFS or determine if a patient has both?
That is a really good question. So I think providers in the field are still trying to determine the difference, but in my opinion, if we look at the diagnostic criteria for ME/CFS, it's really important to recognize there's the post-exertional malaise. So you can have severe fatigue when diagnosed with POTS, but if you also have the post-exertional malaise, that's when there's that gray area. And I think providers have to determine then if you meet the criteria for ME/CFS, and then they may decide that you have both. I know a dysautonomia provider who, once diagnosing individuals with POTS, will not also diagnose them with ME/CFS. So I again think that there's so much more research that needs to be done. There's still a lot that we don't understand. 10 years from now, we may look back at what I'm sharing with you and say, wow, there's so much research. Rachel was completely wrong. Like everything she shared, because there's so much information that we still don't know. The diagnostic criteria may change. You know, we look at ME/CFS and how it used to be called chronic fatigue syndrome. They may decide to change the name of POTS. They may refer to it as something else, because POTS itself can be a little like the name, it can be a little misleading, the acronym. So I just want to reinforce that what I'm sharing with you is related to the most up-to-date research and literature, but it doesn't mean that this is all the information, this is all we're ever going to know about POTS and how it's related to other conditions.
Thank you. Can you share a little bit about your personal experience with POTS?
I can, and I'm only going to share a little bit, otherwise we would be here for a really long time. So I developed POTS in 2019. I was dismissed for years. Because I developed POTS, and at the time we didn't know it was POTS, I was told it was just anxiety. And then, you know, when the pandemic started, I knew that something serious was going on, and I had been previously healthy, but I took even more measures to reduce risk. But at that time, my first symptoms were actually mast cell activation syndromes or symptoms. And then it then delved and morphed into a co-occurring diagnosis of POTS. So that's my MCAS and POTS are very closely related. So as my mast cell activation gets worse, my POTS gets worse. As my mast cell activation improves, my POTS improves. And that's something else that we're seeing in the long COVID community, especially our community, individuals with POTS. They often can have other conditions, not always, but they can. And they can, when one gets worse, the other can also get worse. So I mention that because most of my POTS symptoms have been well managed with mast cell stabilizers. So I will say that when I first developed POTS, my symptoms included, you know, shortness of breath and a rapid heart rate when I would try to clean a bathroom or cook or walk through a store, go grocery shopping. And unfortunately, the providers that I was seeing were not aware of the diagnostic criteria. They thought that my blood pressure needed to drop upon standing in order to meet the diagnostic criteria. And that's not the case. If that's the case and your blood pressure is dropping upon standing when your heart rate's increasing, that is actually looked at as a separate diagnosis of orthostatic hypotension. So I was experiencing a lot of barriers to accessing care because providers were not as familiar with the diagnostic criteria and were not as familiar with POTS. So gradually my symptoms worsened. Unfortunately for me, my symptoms worsened significantly after my first COVID vaccine. And that was very scary. And then at that point, I was on medical leave. I required 2 years of physical therapy, and I still have POTS. I still have to manage my symptoms daily. Sometimes they're worse, sometimes they're better. I'm wearing compression stockings right now. I have to drink a lot, 2 to 3 liters of fluid a day. I've had to get IV saline in the past. So, and I'm on a lot of different medications. So if anyone has any questions, I'm happy to share more, but I also don't want to go into too much detail.
Oh, thank you for sharing. Are there ways to prevent getting POTS that is triggered by a COVID infection?
This is a tricky question because I don't think so. I think there are ways to reduce risk. One being, not taking measures to reduce the risk of infection. For a little while, they thought that vaccination could significantly reduce the risk of long COVID. One study I read suggested that it reduced the risk by around 15%, which is still significant. I don't want to minimize that, but I've also seen individuals who've developed POTS after vaccination, unfortunately. So it's really tricky, and I'm not sure that POTS can be prevented. I think the risk can be reduced, but because we don't have a cure right now, and most of our treatments are specific to symptom management and improving quality of life, I'm not sure that it can be fully prevented.
Wrong button. Our government says that COVID can be treated. Do treatments for COVID prevent POTS? And is there a cure for POTS?
I think there's a difference between treating the acute infection and reducing long-term health challenges post-infection, including but not limited to the development of post-viral illnesses. So I think that, Paxlovid has been shown to help. And of course, vaccination as well, reducing morbidity and mortality. But I don't think these treatments can prevent POTS. I think that they may reduce the risk of developing POTS. But again, COVID infection is only one trigger. There are other triggers that individuals may be exposed to that can lead to the development of POTS. And that's really important for individuals to be aware of too. And what I don't know is if someone is infected with COVID, doesn't develop POTS, doesn't develop long COVID, but maybe if they are in a car accident and have develop a concussion, are they then at increased risk for developing POTS because of the accumulation of triggers, if that makes sense? I don't know. Again, we don't know enough, unfortunately, right now.
Can you share some of the barriers to accessing diagnoses and care that the POTSies face?
Yes. So unfortunately, there are many. If we look at some of the numbers just based on some small analyses that I've done, if we look at 1 in 8 individuals developing long COVID, how many individuals under the long COVID umbrella are developing POTS, and then how many individuals we are estimating then have POTS right now in the US, especially, Bernie Sanders, I think, shared last week, they're estimating that around 16 million individuals in the US alone have long COVID right now. So one of the barriers is access to a provider that understands POTS. And we were already struggling with that before the pandemic. And at that point, there were estimated to be around 3 million individuals with POTS in the United States. And that number has tripled, quadrupled. I'm not sure, but it is significantly higher now. And we were struggling with diagnostic delays prior to the COVID pandemic. So now I've received messages, emails of individuals having to wait a year before seeing a POTS specialist. So prior to knowing that individuals need to see a POTS specialist, they may go to their PCP, they may go to an ER, and they may be dismissed. And that's happening often. So again, it's disbelief, lack of access to needed care. There are financial barriers as well. Sometimes, to see a POTS provider, they may need to travel out of the state, or they may need to travel a few hours and they're not able to, or it may be costly. They may need to pay out of pocket because insurance isn't covering their visit. And again, provider lack of awareness, lack of education. And these are all significant barriers to accessing care and diagnosis.
Thank you. Debbie from our team wanted to ask, I'm sorry if I missed this, what medical specialty do you think is best for doing a diagnosis of POTS?
Honestly, I think if you can find a provider who understands POTS, who believes that you have POTS, or that they believe in POTS as a diagnosis, because that's a barrier, a PCP, cardiologist, neurologist, gastroenterologist, a provider who is willing to listen and willing to perform the necessary testing. Because at this point, I know of incredible PCPs who are diagnosing, and I think there are situations where you can be diagnosed by your PCP, and then if your POTS is more difficult to treat, if your symptoms aren't responding to usual medications that are used, then they can send you to an autonomic specialist. So my answer a few years ago would have been the best provider is probably an autonomic specialist. But at this point, I think it's a provider who's willing to listen, who feels comfortable ruling out other possible conditions and listening to you.
Bruce would like to know, what do you think the long-term impact will be on our healthcare costs?
POTS in general, or long COVID, or?
I assume POTS in general, and he can clarify in chat if that's not what he means.
Well, unfortunately, I view this as a mass disabling event. So I think the costs are going to be significant. Around 25% of individuals with POTS are unable to work, are unable to go to school. We have a number of individuals in our community who require disability assistance. And these are largely young individuals who would like to be able to work, who may have been working prior to developing their condition. So I think the costs are going to be significant, and it's why I'm a really big advocate for masking and reducing risk. And we were saying a few years ago that this was a public health emergency and a mass disabling event. And despite the numbers increasing, it still feels like we're pushing against so many barriers. So I also have hope. I do think that, I know that there's a lot of research being done right now. I have to hope that a number of great minds will come together and hopefully we'll have a cure. But as of right now, we don't. So it's just hard for me to predict what the future will look like. But where there's a will, there's a way. A lot of times, not all the time, but often, I have to hope that there's some really good treatments on the horizon.
I agree. I feel like keeping up that hope is paramount. And we do live in this age where technology is increasing faster. I think faster in the last 10 years than it had advanced in the last 100 years. I know I just butchered that stat, but we just have more and more access to possibilities, and I'm hopeful that solve a lot of healthcare problems, but got to just keep advocating for those even when it's hard. So thank you for that. How can family and caregivers best support the POTSies in their lives?
Oh boy. Believing them. That's the first thing. Believe them. Please believe them. A lot of what they're experiencing may be difficult to understand, but I firmly believe that you don't have to understand someone's experience to believe that it's the case for them. So I think that's the number one priority. And then understanding too, fluctuations in symptom severity. So it can be really difficult for friends and family to see someone with POTS taking part in an outdoor activity on a Wednesday and seeming to have a lot of energy and having less difficulty running around or walking or eating. And then maybe they see them the next day and they can't get off the couch. And understanding that individuals with POTS are susceptible to flare-ups. And similar to ME/CFS and other conditions that we're seeing post-COVID and as post-viral conditions and even autoimmune conditions, the susceptibility to flare-ups, I don't know that that goes away. There are things that we can do to reduce risk, but believing them when they're in a flare-up and not pushing them, because individuals with POTS, individuals with chronic illnesses, or just individuals in general, we know our bodies. So your loved one knows their body and they know when something's off, they know when something's wrong. And, it also really helps to try to learn more about what they're experiencing and ask them what would be helpful instead of assuming what would be helpful, because what might be helpful for you and what might be helpful for your loved one, they could be very different. And there are some phrases that I would also refrain from if possible. It can depend on the person, what's helpful, but toxic positivity can be really unhelpful. Like, oh, it's just going to get better. You just have to push through it. You're going to be fine. You need to be grateful. It could be so much worse. I understand that sometimes those statements are made, they're good intent. There's a good intention behind those statements, but they're often not helpful. And so talking to your loved one, talking to your family member, your friend about, how can I best support you? This isn't familiar to me. I love you. I care about you. Please tell me what would be most helpful, and really listening to them. And the last thing I'll say is self-care. So I always stress that anyone with a chronic condition, and really, I think all humans should try to make room for self-care and that balance and setting healthy boundaries. And that also is important for caregivers and for loved ones, because it can be really difficult to watch someone you care about navigate a chronic condition. And it's really important you can't pour from an empty cup. So it's really important for everyone involved to make sure that they're taking time for self-care. And yeah, I could keep talking about that, but I'm going to stop now.
No, thank you. I was thinking when you were talking about toxic positivity that I think we see a lot of that in the still COVIDing world with non-still COVIDing people, just people who are like, you have an immune system, you'll be fine. It's just one of those things. We just have to stop ourselves from saying those things and think, how can we be positive in like a meaningful and helpful way, rather than, you'll be great. Like this will just knock you down for a little while and then the rest of your life will be great. Like, how do we say things that are actually genuinely helpful? All right. Is anyone safe or immune from POTS, or can anyone get it?
So again, I think there are individuals who are at higher risk, and younger individuals with an assigned female gender at birth, tend to be at higher risk. Individuals with other co-occurring conditions too. So if you have Ehlers-Danlos syndrome, if you have also known as EDS, or if you have mast cell activation syndrome, or you have another autoimmune condition, you may be at increased risk. If you have a history of Epstein-Barr virus infection, if you have a history of Lyme disease, you may be at increased risk. But I don't think that right now, from where I'm sitting and the information that I have, which again may change and likely will change, I don't believe that anyone is immune or fully 100% safe from developing POTS.
Can you talk about how the internet or social media has either increased access to public health information or potentially hindered access to quality public health guidance?
Yes. So the internet has been really helpful and also misleading, depending on, there's confirmation bias, and that's a problem, right? So sometimes we can find sometimes what we're looking for, but after the public health emergency declaration ended in May of 2023, it made things much harder for individuals to look, to find information that they needed about the COVID pandemic and, various numbers regarding, rates of infection in their area, hospitalizations. So I know we're able to thankfully see wastewater levels using CDC and data, but I think it's challenging, and there is some censoring of information. So I know that talking about certain topics like vaccine injuries was really difficult. Talking about long COVID was also very difficult. And again, I think it depends on where you're getting your information from. And I don't think that's fair, because I think that everyone should have access to the information that they need, and then they can determine what they feel is best for them from, having access to that information. But a lot of people didn't seem to have access to the same information, and that is concerning to me.
So kind of on the flip side of that, could you talk about how the internet has provided a sense of community and hope for the high-risk community?
Yes. So I'm not a fan of all or nothing thinking. So I don't like saying that something is all bad or all good. And so even though there have been downsides to having access to the internet during this pandemic and really the last few years, the internet has also saved a lot of lives. And social media has, in my opinion, saved many lives because of that added sense of community, the compassion, the visibility, the understanding that you can get when able to access a community, a long COVID page on Instagram, and seeing someone post about the symptoms they're experiencing after an infection, and they're similar to yours, but you were just dismissed by one of your providers, and you start talking to them about, well, hey, how did you get diagnosed? How did you know where to go? And then they can help you find a provider that might allow you to get access to the treatments that you need. So again, I think that social media has saved lives, and that it's accelerated access to care, not for everyone, but for many. Because if they are being dismissed, or they were being dismissed, they're able to communicate with other people who've experienced either similar symptoms, or they're in a similar situation. And if they're also being dismissed by family members, by friends, and they feel so isolated, that's another piece. And on top of that, the isolation within the chronic illness community is already a big concern. But if we add on a lot of the measures that individuals have had to take to protect themselves from COVID, there's even more isolation, especially if individuals and their family aren't comfortable masking, or their friends aren't comfortable masking, and they're losing friends, they're losing loved ones. The isolation has been really pretty startling, and it's allowed for connection when isolated, physically isolated, but there's still opportunities for emotional connection and meeting people, you know, in other parts of the world he may not have otherwise have been able to meet.
Thank you. Jennifer from the chat would like to know, what are the treatments for POTS and for ME/CFS?
So that's a great question. I'm not as familiar with treatments for ME/CFS. I don't think there are as many that I'm as familiar with. So I'm going to talk more about the POTS treatments. But one of the providers on our medical board does work in an ME/CFS clinic. So if whoever it is, if you'd like to email me, I can connect you with that provider. But when it comes to POTS treatments, there are no cures, but as of right now, there's no cure, but there are medications that can reduce symptom severity, and there are also non-medication options that can reduce symptom severity. So a lot of the helpful medications target a few things. One is heart rate. So individuals with POTS can struggle with high heart rate. So beta blockers have been helpful. But one downside to beta blockers is that they can reduce your heart rate, but they also can reduce your blood pressure. So another medication that seems to be helpful, but is being used off-label, is Corlanor, also known as Avabradine, and it's usually used for heart failure patients, but it's been really helpful for individuals in our community because it lowers heart rate without dropping blood pressure. So that's been a helpful medication. And then there are other medications that help increase blood volume. So one medication that comes to mind is fludrocortisone, and it helps the kidneys absorb and retain, or not absorb, but retain sodium and water to allow for volume expansion. So other non-medication options also try to expand blood volume, so increasing salt intake, again, with provider oversight, increasing fluids with provider oversight, using compression garments to help manage blood pooling. Some individuals have benefited from physical therapy, but there's a fine balance there because of the overlap between ME/CFS and POTS. We need to be really mindful that you're working with a physical therapist who understands how important it is to walk that delicate, or I guess to maintain that delicate balance between physical therapy and exercise and not overdoing it. And other helpful non-medication options might include anti-inflammatory dietary changes. Some have benefited from gluten-free diets. Some have benefited from, having smaller meals throughout the day instead of larger meals. So it really depends. I would stress that any medications or any non-medication options you want to try, that you pass them by your providers, because I'm listing off a number of options, but it doesn't mean that they're necessarily safe.
Kristen in the chat wanted to know if there's anything about low-dose naltrexone. I probably butchered the pronunciation of that, but
No, what's interesting is that low-dose naltrexone seems to be really helpful for individuals with mast cell activation. So when I was talking earlier about this link between mast cell activation and POTS, and And perhaps it's also being used for individuals who only have POTS, but I'm not as familiar with that, so I don't want to speak to that. But I am more familiar with its use in individuals with mast cell activation. And there's a link and there's an intricate relationship between mast cell activation and POTS. So again, from my personal experience, when I treated my underlying mast cell activation, my POTS improved. So if individuals are being started on low-dose naltrexone and they're finding that it's helping their mast cell activation and then their POTS is improving, it may be a similar relationship. And that's something that we really need to keep in mind. So, and there's a large inflammatory component for individuals with POTS. So triggers that increase inflammation can make the symptoms worse. I can't speak for everyone, but that's a pattern that we've been seeing.
What is the best way to contact you if any of our chat members want to reach out to the professionals that you know?
So, and I can't fully promise that they'll be able to talk to them directly, but I can speak with them and coordinate, and you'll likely mostly be talking with me, but I can talk with them as well about potential options. You can I'll put my email in the chat if that's okay. Or it's awarenessforpotsies@gmail.com.
I just popped it in the chat. Awareness for POTSies, POTSies @gmail.com.
Yep.
Okay. Thank you for that. All right. We are going to wrap up here in the next couple of minutes. Is there anything in particular that we didn't address today that you would really like to address before we wrap up?
Let's see. Well, being that I used to work in acute care, but now I'm largely working in the mental health field, I do want to also emphasize the significant mental health concerns that I have for individuals with long COVID, individuals with POTS. We have a pretty high suicide risk in our community. So that's really something that we need to be mindful of. And I've seen and read that that's also consistent within the long COVID community too. So that is a concern that I have, and I want, if anyone's listening and they can talk to their providers, or maybe it's something that you've also been experiencing, but you feel that you might be the only one, you're not alone. And I would just, as a crisis counselor, also want to remind everyone there are people who care. There are people who want to help, and you're not alone. Even when you feel alone, there are resources out there. Your life matters, and we want you to, we want to give you hope that as hard as it may be right now, we hope that it's not always going to be this difficult. And that's a really important thing that I just want to mention.
Thank you so much for being here and your time. And I know that it's difficult sometimes to make the time to carve out a full hour, so we really appreciate it. And again, if anyone would like to get in touch with Rachel about treatments or providers, her email is awarenessforpotsies@gmail.com. We have that in the chat. And also Rachel's Donna just popped in the chat to say thank you very much for your discussion with us this evening. I've learned a lot tonight, and I really appreciate you taking the time to share your experience and expertise with us all. Best wishes for feeling better as soon as possible, and thank you. And I'm sure that everyone here echoes those sentiments. So yeah, thank you so much for being here. For everyone else, we are going to take a quick break so that you can grab a snack or use the bathroom or whatever you need to do. Our next speaker is going to be Dr. Angelique Corthals, and it's going to be a great session. So please stick around, and we'll see you in a couple of minutes. All right, welcome back, everyone. Thanks for being here. Our next speaker is going to be Dr. Angelique Corthals, but first I will turn it over to Julie Lamb for a quick introduction.
Hi, everyone. As Mask Together America's founder, I'm excited to see all of you here at our third webinar of Brace for COVID-19 Wave 2024 with Love, an expert forum our team put together to address the ongoing pandemic. For 4 years, COVID has decreased life expectancy, According to the International Monetary Fund, this unprecedented global health and economic crisis could cost about 13.8 trillion US dollars globally by 2024. In the US, estimated at least 4 million are out of work due to the wide range of incurable symptoms, organ damage, and COVID-induced autoimmune disorders after getting COVID-19. We are talking about 170 billion lost wages a year. 20 million Americans already have long COVID, and the population of long haulers will continue to grow as our government continues to be reactive instead of proactive in their COVID response. According to a research paper published by Brown University School of Public Health, US ranked 38th out of 60 high-income countries in number of physicians per capita. US ranked 40th for number of hospital beds per capita. US ranked 175th in the world for access to healthcare due to lack of universal health coverage and high out-of-pocket healthcare costs. Healthcare is a human right, yet healthcare is unaffordable in the US unless you have access to adequate health coverage. Why is the US COVID response failing us? And what can we do? Is tonight's topic. And we are extremely fortunate that Dr. Angelique Corthals can find time to be our guest speaker tonight. Without further ado, I'm passing the mic back to Sarah, and she will introduce our advisor, Dr. Angelique Corthals.
All right, thank you so much. Dr. Corthals is one of our board members here at MaskTogetherAmerica, and she is a professor at John Jay College, a renowned expert in infectious disease, conservation biology. She's done research on bats and coronaviruses, so that is pretty spot on for what we're looking for here. I do not have anything pre-written about you, Dr. Corthals, so I'm sorry. I'm doing my best to remember all of the highlights. My personal highlight is I watched a movie that she was in an IMAX theater when I was in school, the Egyptian mummies movie. So that's my favorite thing in your background. But she is an expert, and we are very glad to have her here for our Q&A session. She's going to share her expertise on COVID-19, give us her valuable perspective on the current state of the pandemic, preventative measures that we can take, future developments, and we are very lucky to have her here. So as always, please drop your questions in the chat panel, and I will get to them as quickly as possible and get as many in as possible, because this is a great opportunity to talk to an expert about any burning question you have about COVID. So I'm going to start by sharing this image. We had this article from AP about states trashing this PPE stash. An Associated Press investigation found at least 15 states from Alaska to Vermont have tossed some of their trove of PPE because of expiration, surpluses, and lack of willing takers. More than 18 million masks, 22 million gowns, 500,000 gloves, and more straight into the trash. So our audience has been wondering what should have been done to prevent wastefulness in this area.
So the first thing that should have been done is actually using the PPE, just at the top of my head, rather than deciding that masks were no longer useful in a healthcare setting. And that's the top priority. Second, expiry dates for PPEs are very just like the expiry dates for your food, they're very variable. And N95 do have an expiry date in that they are electrospun, meaning that they do lose their, not so much their filtration system, but they're losing the ability of the fibers to retain small, tiny particles like viruses because of that electrospinning. Now, instead of putting them in the trash, of course, they can always be recycled. So they could be sent back to 3M, for example, be recycled, re-electrospun, and reissued, maybe at a lower cost. That's not happening. Even 3M has been trashing some of its raw material because there is not enough demand for the masks anymore worldwide. In terms of the gowns and the gloves, there's really no expiry date unless when you open them, the gloves are stiff or stiff because they've been there for 20, 50 years. They're after all plastic gloves, right, of some kind of. They're no longer latex, most of them, but and the gowns certainly is the same situation, right? They're good until they're falling apart inside their packaging. So gloves can be porous, so you have to be more careful about the glove potentially, but still their life cycle is extremely long, much longer than the expiry date given by the producer of the glove or the manufacturer of the gloves. The why it's being done is, I'm not going to go into that because we're getting into the political sphere, but it's obvious that it's been a political decision to stop mitigation at so many levels, and that's part of the problem. And this is the results. This in tremendous ways has been the result. And again, also the political will is not there at each of the states level, for example, to redistribute those PPE to people who would need it, who desperately need it, or even for people who are willing to continue mitigating COVID.
So on that note, Jennifer from the chat would like to know, can masks expire? They purchased N95s at the beginning of the pandemic, haven't used them. Are they still good a couple of years later?
Yeah, masks can expire. So especially N95, they become more porous. So all masks can expire. They become more porous in general, but N95 particularly, because they're losing that electrostatic element, which makes them so very efficient at filtrating very small particle like viruses. So I would say that an N95 is good for upward of 5 years. After 5 years, we can imagine that they're starting to lose their electrostatic element to them.
Thank you so much. Why is the US COVID response failing us, and what can we do about it?
So there's so many ways. There are so many ways to answer that, which is not good. The first and most obvious one is probably the fact that we don't have universal healthcare. So access to healthcare is a big problem in this country. There's also not enough physicians, and that's actually part of the problem. It's all linked together, right? But so rural areas, for example, don't have enough physicians. There's not enough access to healthcare there. But even in urban areas, there's not enough access to healthcare because people literally do not have the time for, and time is money, because by saying the time, I mean they can't afford taking off work. They have to, they can't juggle getting access to healthcare. And if it's between getting access to healthcare and putting food on the table, you know, okay, taking care of your family, there's definitely that's the biggest problem of all in the United States. But if you look at mortality in places which do have universal healthcare, hasn't been great either, you know, and especially now that mitigation have just been relegated to the realm of the past for as far as administrations around the world are concerned. It's not great. Still better than the United States, but not great nonetheless. So there's something else going on there behind the scene, and that shouldn't be my expertise. Unfortunately, I've been looking too much into it, and I don't want to depress everybody here, but the problem is that we need a different system where people are important rather than the capital that they produce as workers. And well, when production and economy is more important than the health of the citizen, then we have a problem. And this is, I think, what is the biggest problem of the pandemic, is that it's been a go back to, dear peasants, go back to the farm to produce and produce and produce because the economy wants it. And that's, if anybody is in doubt of that, as if anybody was in doubt that this was the case before the pandemic should have put that very much in the forefront, that we are in a system, and it's worldwide. It's not just the United States, but of course, it's far more flagrant in the United States, where the economy is more important than the individual citizen or the health of the citizens in general. And we need to change that. And I, you know, at the very beginning of the pandemic, there was this amazing current where it seems things were going to change, and that that narrative was quickly taken over, shoved in the shoved aside, and sort of muted over the message that everything was fine now. We have the vaccine relax, etc., etc. And we've seen that vaccine relax does not do well in terms of public health.
Thank you. Our advisor, Dr. Green, wanted to ask, how do you feel about long COVID advocates linking long COVID with AIDS? Do you think that this is a misrepresentation or exaggeration that could undermine credibility?
Well, so this is a difficult question. There are none of these questions have a yes or no, black or white answer. All of those live in the gray. And I think this is where we should keep, I very much like our two previous speakers mentioned that as well. We should keep our discourse very much in the gray when these kinds of subjects come along. So there is a similarity between AIDS and long COVID in that, just like AIDS patient, we have to advocate to the administration. Without the advocacy of groups like MaskTogetherAmerica and long COVID families, etc., all of the long COVID groups that are out there, without that advocacy, we wouldn't be seeing what we're starting to see, to a very slow grind, but we're starting to see it, those rollout of long COVID programs all over the country that are starting to appear, and that are starting to basically reflect the level of advocacy that's been happening. This has been the same thing for AIDS. So I've been working with Doctors Without Borders, and from the very beginning, Doctors Without Borders has been a big advocate for AIDS patients in countries that, for example, didn't where the administration did not believe in the link between HIV or AIDS. So patient had no way of accessing antiretrovirals that they needed. And so what we've been doing with them is a level of advocacy to continuously repeat the message, this is happening, this is disabling, this is citizens are dying, etc., and reaching all the levels of government little by little to develop a response to both AIDS and long COVID that is absolutely necessary. So in that respect, in the respect of advocacy, we're seeing a lot of parallels, because we really, patients have to advocate for themselves. And there's a lot of isolation. There's a lot of feeling of isolation and actual isolation happening. So it's very important that what we saw early on for AIDS is happening at the COVID level. Now, whether it is similar biologically, that's an entirely different question. So there are similarities in that, yes, COVID does weaken the immune systems, and yes, there is an action on the T cells, etc. However, it is not at all through the same mechanism. So we cannot say that HIV and COVID have the same mechanism of action at all. They don't. They may have similar effect, but that doesn't mean that they are acting in the same way. So very careful with this. Again, long answer, but those long answers are necessary.
Veronica in the chat would like to know, how would you propose that people from the general public help make the changes for those who don't value us or other people enough to take precautions?
Keep supporting people who do. I think that's the most important. And just like AIDS, for example, in terms of advocacy, what really helped was the fact that the advocacy was to first bring in the general population who may not have had any kind of desire to back AIDS patients to the table and say, look, protecting our AIDS patient is protecting yourselves, protecting the entire community. It's not an individual thing. It's a community level thing, and it's very important that we get as much support as we can, because strength in number, right? And if we can find enough people who potentially are not affected or don't think they are not affected with COVID and don't think they will ever be affected with COVID, but to understand that it is important to act as a community to protect ourselves, then we can go further, because then we start getting noticed by those who are in power, right? Who have actually the ability to act on protecting us, even if they often don't have the will.
Thank you. Donna would like to know, how do we know this abrogation of public health responsibilities stemmed from political decisions versus driven by donations to influence political decisions from the wealthy to keep workers working for the short term. I'm thinking of the CDC caving to the airline executive's request to change the COVID isolation period to 5 days. Is there a clear trail of decision making that is in the open?
Yeah, I think yes, it should be pretty blatant. And that's the thing is that's kind of the sad thing is that it's, people like to speak in terms of conspiracy. There's no conspiracy. It's right there. You can see who's influencing who. Political and economical, political decisions and lobbying power is the same thing nowadays, right? And this is a big problem. We have a system that's obviously breaking down, and we're in the middle of it. With COVID is actually something that is interesting, because I think we'll look back on COVID hopefully as a turning point where there's it's sort of raising awareness that something needs to be done globally, but also that communities are very important and can help change situations at a global level. And I'm hoping that we will see that effect, unlike the epidemic of the flu in 1918, which unfortunately happened at an inauspicious time, meaning that we just come from a world war, which was slightly more important, and we're going straight into another world war. And so the bandwidth for change in that respect was not quite there, or it was, but it turned into a complete mess. So I'm really hoping that I see this a lot with the younger generation, and they're starting to see that the threats on democracy, the lack of access to health care, the power of lobbying in politics, all of that is linked together, and that yes, politics can kill you, right? They're starting to see that. I think it was something that was very abstract in a lot of, I see that in my students. It's something that was very abstract. So if we think of big world events like Second World War, yes, politics did kill, right? We saw it. But that was always something that was historical. With COVID, they're really seeing that it's happening, and it can happen at a micro level. It doesn't have to be this, this massive world war event. It's not just about fighting each other. It actually can happen because of a virus.
Thank you. Veronica from the chat would like to know, how can advocates and activists change our messaging to be more appealing for those who are uninformed about the dangers of COVID so that they are moved to take precautions?
So this, I think we have somebody on the board of Mask Together America who's just the best at giving that answer. I don't know if she's here today, but this is a member of the board at Mask Together who always advocate love, and that's absolutely true. Is that if you force something onto somebody, or you try to have a forceful message, it's really not gonna work. And we're human. I mean, if you tell me today you shouldn't touch that button, I will try to touch that button desperately, right? So this is just our human mind. This is how it works. So if we can try to have messaging, so again, my experience with Doctors Without Borders started was formative in that the way we started getting the message, for example, so it's the equivalent, if you will, of people having protected sex, right? How do you get this into a population that is absolutely reticent to use condoms? And that actually came through community leaders. If you get the message and convince community leaders that doing the right thing in terms of mitigation is going to protect their community, then these leaders will take care of their community, and then it's going to spread exponentially from there. But these are the people you have to reach. And this is the target, so to speak. So these are the people that you have to convince. That's how you work it out.
Ken would like to know, what should we do when one day there's no more government funding for free rapid test kits and drug companies start charging for Paxlovid?
This is a difficult question. We march on Washington, basically. You would just do a sit-in on the steps of the Capitol and say, look, this pandemic's not over. And that's the only thing we can do. We have to petition the government, right? And if one person petitioned the government, they can be sweated away like a fly. If 1,000 people start petitioning their government, they're starting to notice, right? And so, and it doesn't have to start with, going to your senator immediately. You can start at local government. You go to your town meetings and you say, hey, I need this. I need tests. We need masks. You go to your town meetings with a group of 10 people. I promise you, they will start taking notice. And then from the town meetings, you go to the county meetings. And from the county meetings, you go to the state level meetings. So from New York, for example, you go and petition people in Albany. And then from there, you start going to the federal level. But trying to petition just one group at the top is not going to work, because there's never going to be enough people to do that. So we have to start very locally. And I promise you that local governments have a lot of funds that they could allocate for testing and even for distribution of masks. But you have to organize. And you have to organize locally. So find your progressive Democrats out there and join their group and say, hey, there's this problem. We need to address it. Can we join forces? Let's try to you will always get, it is your right as a citizen to get a meeting with your local representative from the town, from the county, and from the state. It is your right as well to go all the way to the federal government, but in the federal government, it's going to have a moderate amount of success. But at local meetings, you can actually get things done, and you can get supplies distributed if you have enough people behind you to convince them to keep that distribution of tests for free.
Thank you. Zena in the chat would like to know, are we finding studies that are showing that COVID stays in our bodies the way that Epstein-Barr virus lays dormant? Is it hiding like a ghost? Is it not shedding out of our systems?
So there has been quite a few studies that have shown that there is a sort of latency side to COVID. it hasn't been quite explained yet, so it's not quite like the very complex latency system that occurs for herpes and the chickenpox and zona and zoster, for example. However, there is a latency that happens, and that's been shown. There's also been a couple of studies that have shown that the same patients can be reinfected with COVID from their own latent source of COVID. And that's only been shown with a few patients. Unfortunately, it's a numbers game, right? So when you have n equals 1 in science, it's never a good thing. So you want to have n equals 100, but you have to find those patients. You have to have the healthcare team that is aware and enough to actually undertake those studies, and of course you have to have patients' consent, right? So it's getting harder and harder to get these studies done, because with the cavalier attitude that it's been instilled in the public towards COVID, and we're finding fewer and fewer people that are willing to participate in studies that are absolutely vital. So a lot of studies, if you look at the literature, a lot of studies were done on patients that were pre-vaccination, and that's actually a big problem, because we needed patients that are post-vaccination, especially post-booster vaccinations, so we can understand what the incidence and the influence of vaccination on all of those mechanisms that have been fairly well described prior to vaccination to now. So yes, to that respect, yes. In fact, that's actually part of my research. So I do research on goblet cells, and the goblet cells are those mucus cells that makes your nose run, or that coats your intestine to pass the food along, and the reject of the food along. And those goblet cells are very sensitive to COVID, meaning that they are sensitive in that COVID can attach and enter those goblet cells, but they do not die like an immune cells, for example. They stay functional, and they may actually be a reservoir for COVID. They've been shown to be reservoir for viruses in other diseases, in the other viral diseases, particularly Ebola. So there's a similarity in that mucous membranes, so your nose, your intestine, your eyes, the inside of your mouth, which contains those goblet cells, are very susceptible to viral diseases, and the viruses out there seems to be very well primed at using that nick in our armor.
Related to that question, Donna wanted to know if there are differences in the goblet cells in folks who are immunocompromised.
Yes, to an extent, in that they are not producing as much, so they are not calling as much for the production of interferons, for example, which are the primer, sort of the Marines on the beach against viruses. So they have a more subdued level, but in terms of expressing the receptor to viruses, or especially to COVID, they seem to be the same, because that doesn't have really an influence on immunity. But again, with immunocompromised patients, there's also other, it's not just the immune system that's dysregulated. There's other things that are dysregulated, including their metabolism. And because their metabolism is dysregulated, then it changes the balance of how your cells react. All of your cells react to external threats.
Question from Holly. After 4 years of slugging through the pandemic, how do we realistically not lose hope? The isolation and nostalgia for something else is crushing some days. Thank you.
Yeah. I completely understand. This is crushing every now and then. I can totally relate because when I went back in person, so I still am technically. I was on the COVID emergency committee of my college, and still am, even though that committee is pretty much disbanded by now. So I'm the only one left. When I went back to in-person teaching, and as the college was having these regular meetings on mitigations and how can we safely go back to teaching, I saw these efforts just going down and down and down and down and down, with the peak being between the January 2021 and September 2022, where basically it was like, who cares? Pretty much the whole COVID emergency committee disbanded and was relegated to being the COVID person on the Senate meeting. And that was absolutely crushing. I just thought, what the hell? It's still going on. And I was still giving, with a lot more sarcasm, I was giving my sort of monthly update to the Senate saying, what the hell? Why aren't you paying attention? But you know what? As crushing as it is, I continue doing it. Again, I've ramped up my level of sarcasm to 150 million%. So I do use a lot of humor, but it's very sarcastic in my slides. If you go on the slides that I prepare for the Senate, I put them on my website so that everybody can have access to them. You can see the progression. Like as I'm being less and less heard, the sarcasm goes up and up. And I understand it is crushing, it's isolating, but keep at it because you're doing the right thing. What you're doing is you're protecting your community. And if you ever feel bad, this is the message that you have to remember. You are a part of this long chain. It may be visible sometimes because you don't see everybody who's involved, but this chain of people who are willing to go the extra mile to protect their communities. And if you keep at it, eventually it can only do good. You will never go bad in trying to protect your community, right? So keep at it. Just think of all the good that you're doing by keeping at it, and find your people. This is the beauty of, I'm the worst person on social media. I don't know exactly how to use it. Not entirely sure how Instagram works. I barely got around Facebook, and don't even talk about X or Twitter. But what I find really amazing about social media, aside of all the cons, is the fact that you can find your people. Find your people. Just find your support group.
Thank you. Bruce would like to know, what would you suggest we do differently now if COVID is becoming our most significant health risk in the next year or two?
keep protecting yourself, and keep sending out the message that mitigation is important. That's all we can do right now. So continue using layered protection, layered mitigation. Continue encouraging others, even if people laugh at you, it's fine. You know, being laughed at has never killed anybody. Continue telling people, keeping your message out there. Don't be forceful about it, but just tell them, hey, you know what? It actually is better. I mean, you could, you know, what's the worst that could happen in terms of telling people, tell them what's the worst that could happen to you, you know, what by putting a mask on, right? As opposed to what the worst that could happen to you would happen if you're not putting a mask on. So you have like this balance of things. So like there's a possibility, and again, you know, you might never get long COVID, right? So, but you may get it. And then what? Is it worth it? So you do a bit of the Pascal bet on that. Like, so, you know, if you protect yourself, your chances of not developing long COVID are raising to 90, 95, 99%. If you don't protect yourself, your chances of developing COVID are long COVID are much higher. So just try to impress on them that there is an other side to getting infected with COVID all the time, and that it's not just a cold. You have to have a conversation. See, the thing is, you can't convince people by getting red in the face and yelling at them. And even though deep down, this is what you want to do, you just want to take people on. Like every time I take the train and I see nobody's masking, half of the train is coughing or sneezing. And I just want to take each of them and shake them and say, what the hell are you doing? Also, you know, how can you afford the time to be sick all the time? Just personally, I couldn't afford the time to be, infected every 2-3 months. So why not do this very simple gesture that would tremendously improve your quality of life, right? And I hate to say it, but we need to take a book out of the horrible movement that is happening currently in America. Is that we are seeing a very radical right movement that's rising, and it's not just rising here; it's rising all over the world. But this movement is actually started at local level. We have to do that, actually. We have to start conversation at local levels and start, very gently convincing people that, not convincing people because you never do it, but putting the bug in their ear, so to speak, that mitigations and layered mitigation are important. They're about protecting people. They're about love. They're about they're about having a healthy future, not just for you, but for the next generation, without affecting your everyday life. I mean, sure, wearing a mask is not fun, but think of, for example, emphasizing clean air. What is the downside of having clean air? What's the downside of that? So you can start the conversation like that. So if somebody said, well, I don't want to have a HEPA filter because blah, it's like, okay, understandably, it's expensive to have a HEPA filter retrofitted, but what is the downside of having HEPA filter? And if we get to petition local government and then middle governments and then eventually the federal government, this can all be financed, right? So little by little, just literally community work. This is the only way we can do this, because I've seen it, I've been part of it. Doctors Without Borders is actually has been so successful in their treatment of HIV/AIDS because of that work in places where it was deemed absolutely impossible to get treatment for people, or to even get people to understand safe sex, right? So same thing with masks. It's a change of mentality, and you cannot change mentality by telling people what to do. I think that it can only be done if the message is repeated over and over again. Like Julie knows best.
All right, we've got time for maybe one, maybe two more questions. So I'm going in order here. Alice in the chat would like to know, how can we best advocate for community leaders to require and provide effective masks and take other needed COVID safety precautions at their events, and to encourage them to let community members know about the importance of effective mask requirements to get community buy-in?
So one of the best way would be to representation matters, right? And one of the best way would be to find somebody who's charismatic, who's a community leader, to agree to wear a mask and to try to convince them that this is an important thing to do to protect their community, that this is not about impeding their everyday life. Masks have not impeded me in my everyday life at all. I mean, I can't say that this is the most comfortable thing to wear an N95 everywhere, but I can't say this is the worst thing either. And so if they are represented, if you have this representation in front of you, if you have an example, then your message starts to spread. But again, you have to start at the most basic level. I mean, just to give you an example, I wear a mask in class. And at the beginning of the semester, I'm always the only person in the class that's masking, save for maybe one other students. By the end of the semester, usually half of this class is wearing a mask, 2/3, right? And again, it's because they're seeing somebody with a mask, and they are understanding the message by seeing me not being sick that semester, unlike all the other faculty that's not wearing a mask, or all the other students that are not wearing masks. They're seeing that there's a benefit to this, right? And they're also seeing somebody in front of them, a person of, I wouldn't say of power, but at least a person of authority, a person that they recognize as not so much a leader, but as somebody you can trust, wearing a mask. They start to emulate this, and it doesn't happen it doesn't happen right away, by the way. Those masks appear throughout the semester, and they start growing and growing. So it requires a lot of patience, and nothing happens overnight. And particularly with this pandemic, which really happened at a problematic time, it's going to take a long time. And yeah, I'm seeing a lot of things happening in the chat. I don't have time to look at it, but I saw somebody mentioning mentioning representation. It's very important that we start rebuilding the pieces of public health that have been destroyed by the follow-up to the response to the pandemic.
All right, thank you so much. That's kind of all the time we have for Q&A. Dr. Corthals, if you have any final thing that you want to bring up that we didn't get to touch on, the floor is yours.
Sure. Well, I understand a lot of you are here because you're finding your people, first of all, so congratulations on that. You found your people, but also that you're trying to be less isolated and you're feeling crushed by this lack of awareness and this reluctance to by the administration, by all the powers that be to apply mitigation to this virus that we know is not a cold, that we know has long-term consequences. But guess what? My message to you is keep doing what you're doing, keep coming to these experts webinar, wherever you find them, and take that and spread them in your own community. And every one of us is going to be basically, I don't want to say a chain of transmission because that sounds bad, but every one of us should act like a virus and transmit this knowledge exponentially. And this is the only way we're going to manage to put that message out there and ensure that this message is going to eventually resonate at all administrative levels, so that we can keep getting the care that we need, and we can rebuild a healthcare system that is geared towards the health of every citizen, not just a few.
Hear, hear. Thank you so much, Dr. Corthals. We really appreciate having you on here. And wow, we had like 20 questions written up for you, and we got to one of them because the chat was just so excited to have you here. So thank you guys so much for providing those great questions. We really appreciate it. Thank you, Dr. Corthals, for sharing your valuable time with us to educate us and inspire us. And I know a lot of people in the chat are saying that they really, really appreciate that you're a visible person in academia who is still masking, and that makes a huge difference for the students and the people that you interact with on a daily basis. So thank you so much. Thank you all for being here. We are going to get into our final session of the night with Aaron Collins, the mask nerd. So excited to see a fellow Twin Cities person on here. All of my mask people are like in other corners of the country. And so I'm like, am I the only one? No, I'm not. We've got Aaron. So I'm going to turn it over to Julie Lamb really quick to give a brief intro of the session.
So as a volunteer, I'm also a volunteer here. Volunteer of MaskTogetherAmerica, I welcome all of you to the last webinar of tonight. Over the last 4 years, studies continue to pile up showing COVID-19 can cause serious illness, affecting every organ system in the body, even in vaccinated people with seemingly mild infections. It can cause cognitive impairment like brain injury, trigger immune damage and dysfunction, impair liver, kidney, lung, heart, increase the risk of neuropathy, cardiovascular disease, and all kinds of autoimmune disorders, including diabetes. A previously healthy, fit, and young person can lose their ability to work and exercise, unable to recover for months, even years. It's frustrating to see public health messaging minimizing the health risk instead of investing in long-term strategies for proper mitigation. It's frustrating to see public health guidance getting weakened and politicians minimizing the health risk, refusing to set standards for indoor air quality to contain airborne transmission. Tonight, we are super honored to have a clean air discussion with our distinctive guest speaker, Aaron Collins, the mask nerd. Without further ado, I will pass the mic back to Sarah, and she will introduce our guest speaker to all of you.
All right. Thank you all for being here. Thank you, Aaron, for being here. The chat has just been blowing up for a long time. Excited that you're going to be here. So for those of you who don't know, which at this point it seems like everybody does, Aaron Collins is a mechanical engineer with a background in aerosol science who's been testing and evaluating masks and sharing his findings on YouTube and his ever-growing Google Doc. This work resulted in a variety of media appearances, including the New York Times, Wall Street Journal, Scientific American, CBS Mornings, Good Morning America, CNN, and BBC Radio. Aaron is also a passionate advocate for clean indoor air, having helped form Open Arrows, an open source hardware company focused around meteorology in the clean air space, as well as the OSLUV Project, a 501c3 nonprofit tackling mitigations and solutions to equitably bringing clean air to those most impacted by the COVID-19 pandemic. So thank you so much, Aaron, for being here. We're really excited to have you.
My pleasure.
We wanted to kick this off actually by sharing a video from the CDC and getting your thoughts on it. So I'm going to share my screen here.
Winnie is holding a mask. She is an American Indian girl with cerebral palsy who uses a wheelchair.
Stay safe from COVID-19.
Winnie's dad shows her how to wear a mask. Winnie puts her mask on.
Wear a mask so you won't get sick.
Winnie leaves for school. Dad waves goodbye.
Wear your mask when you go to school.
Winnie rides the school bus. Her friend Alice sits behind her.
Wear your mask on the bus.
Winnie is in a classroom with her friends Alice and Sam. Sam is wearing a mask, just like Winnie.
Wear your mask in the classroom. Some people wear masks. Some people don't wear masks.
Here's Winnie, and here are the kids in her class. Some kids wear masks, and other kids don't.
That's okay.
Winnie points to her mask.
You can wear a mask so you won't get sick.
Winnie, Alice, and Sam eat lunch in the cafeteria. Their masks are off.
You can take your mask off to eat lunch.
Winnie puts her mask back on.
When you're done eating, put your mask back on.
Winnie and her friends are back in the classroom.
Keep your mask on for the rest of your day at school.
Winnie, Alice, and Sam play in Winnie's living room.
Wear your mask when friends come to your house, too.
Winnie and her dad look out the window. They see Alice and Sam waving goodbye. Winnie is not wearing her mask anymore.
When your friends go home, you can take your mask off.
Logo, CDC. Learn more at www.cdc.gov.
All right, so very interesting video. The CDC shared this about masking as a personal choice to avoid sickness, as shown in the animation, and they show children unmasking and eating together. Does this message follow the science for infection control?
Yeah, I mean, I think it's, this topic is actually quite complicated. And I think it's good that this video is a good demonstration of it. So I think first, let's look at the positives that CDC was trying to tackle with this. To me, the video was intended for children and is to normalize mask wearing. And I think that that's a good attempt, right? We want to normalize people wearing masks in public settings and not be outstanding. But I think there's some big missing pieces Notwithstanding the kind of weird AI voice, I think it almost feels a little dystopian, like some of the way it was shot. But I think it's also lacking a lot of context. So if it was intended for children, okay, that's a good first step. It's missing a lot of the important information that we'd want to hear in a video. One, what are good mask choices? So we're just using mask as this ubiquitous term when we know that there's really good data about better masks and that fit better to the face. And that's probably the most important thing that we'll be dealing with in the future when we talk about masking. I think the other important thing that it didn't really cover is that you can wear a mask when you're sick, or that there are other tools in the tool chest that help us tackle, avoiding being sick. So saying, oh, we all tested and we had our friends over, right? So we built these layers. We opened the windows, right? There's like these mitigation layers. So to me, yeah, a good first try. I mean, I guess it's better than what I've seen out of CDC for a long time. It's about 4 years too late, but I think, yeah, it's missing a lot of the context about masking. I think the lunch one is a really interesting one. I have a child myself, and at this point in time, I think maybe there's only 1 or 2 kids in the school left masking, and Elliot does a pretty good job about it. And I think that the lunch one is actually really difficult. I live in Minnesota, probably along with you, Sarah, although it's not so cold this winter, but last week it was very cold, right? And so like considerations of like outdoor eating and stuff like that aren't really an option here. So I think it's also important to think about when we think about risk of transmission and risk of disease transmission, there's kind of a lot of factors that go into it, right? So it's how many people are in the space, what's the community case in the rate, case rate in the space, what activity is happening, and the duration. And so I think we have to think about all those things together. And so in some ways, like keeping your mask off for a short duration where you have to eat in school, we just sometimes have to do the best we can. Is that what I would want to happen long term? No, I think there's a lot of other mitigations we could use. We can make schools way safer for, so many children and then also their parents and loved ones. And so I think that the CDC did a good first job, but yeah, they're missing just a lot of the important context, which is really critical when we're explaining masks, because I could talk an hour straight on this topic easily. And I feel like there's so much nuance to this, and so many people have to be educated about it that a 1 minute and 20-second video. The other good thing I did see is that they had the windows open. So hey, ventilation and outdoor air. at least they're hitting some of the points, I guess.
Thank you. And you make a good point. I think a previous speaker brought up that we don't want to cast things as all good or all bad. There are certainly some important messages in that CDC video. And if it makes a child feel more comfortable masking or less like, bullying another child for masking, that's always a good thing.
Right.
The chat has been popping off with questions, so we've got a ton to get through here. First question comes from Stephanie. Stephanie would like to know, do you think there is any case in regard to the ADA that without better indoor air quality, the immunocompromised community is being discriminated against because inadequate air quality restricts access to communal spaces? As a follow-up, what do you think it would take to get ASHRAE air quality standards adopted as law?
Yeah, that's actually a great question. I do very much view indoor air quality as a disability issue as well, right? We are excluding a huge section of our population by not encouraging clean indoor air, especially in public spaces, which both could be like the legal term for that. We're accommodating in public spaces. And so 100%, yes, we are, I think fundamentally the thing that, and I don't want to pretend like I was like a super expert in a long time, but I definitely come way more familiar with the disability issues of having worked with a lot of people finding masks that are in that space. And it's really opened my eyes a lot. And watching this over the last 4 years is like, if anything, it's been really frustrating for me. And that's why I had founded the 501c3 Oslo project. Because to me, it's so frustrating is that in many ways, the immunocompromised, disabled portion of our communities are really being, ostracized, excluded. And in some ways, like almost like there's this whole mental thing that I see happening where it's like, oh, well, those people will get sick, but I can go have fun and party and we'll spread COVID. But, don't let those people ruin my fun. And it's super messed up. So it's been something I've been focusing on and thinking about a lot lately. I think the adopting of ASHRAE standards and this whole process of making systematic change, unfortunately, is way too slow. And so I think having action and community groups come together to really advocate for clean indoor air. Johns Hopkins University issued a sample state legislation for clean indoor air. And I think the one issue that we have is that ASHRAE 241P, or 241 now, they took the P out, is that it's not fully gone through the ASHRAE voting process. So it's still like in the works and in the process. And so that just needs to get done. And then we can get written into legislation for spaces. I think one of the challenges is going to be adoption of that. How do we put interlock? Because there's some exclusions about occupancy. You can reduce occupancy or it can increase airflow rate. And I feel like it'll be interesting to see how that all plays out. But I think that that's the systematic change we need. We need legislatures to pass laws and building codes to be updated, and it can't happen fast enough.
Thank you. Christina would like to know, is it okay to let my N95 sit out on my dresser between wearings, or does sitting out affect the electrostatic properties and the effectiveness?
It's a really good question. So totally fine to leave it out. I think you do need to be, assuming it's not, you're outdoors, it's an indoor space, it's not going to get wet or rained on or something like that. I've had masked. Unfortunately, I've left them outside. They don't work so well if you leave them in the rain out in the sun for a week too. But as long as it's indoors, sitting on a dresser, no problem at all. They can be reworn. What we want to look for with reuse of respirators, though, is we want to make sure that the respirator is fitting tightly to the face steel. So the face, excuse me. And so what can happen is when we look at respirators, the head straps or the ear loops, if you're wearing an ear loop version, they're going to stretch out over time. The mask can lose some of its structure. And so what we're looking for on rewear is to make sure that it's still providing that great seal, because that's where the magic's happening with the N95. The filter media is so high performing that most of the leakage is going to happen at the seal interface. So good face fit, good seal is good protection. And so that's what you want to keep a focus on. But that filter media, it's pretty rock solid.
Thank you. How long do we think unused and packed 3M N95 masks can last?
Good question. So CDC and NIOSH did a bunch of evaluations looking at the stockpile of masks in around 2020 and 2021. And some of these masks, and some of them were 3M, were like 15 years old and like 10 years past the expiration date. Now, why these were in our stockpile, I have no idea why, but that was standing. It was a great test. They actually went and tested those masks for filtration efficiency and found that even masks that were far beyond their expiration date still filtered, and pressure drop and everything was nearly exactly the same. In some, actually, in one instance, it was better than the current produced varieties. And what it highlights is that the electrostatic melt blown is very stable for long time periods. The issue that we're going to have is that the rubber and foam will degrade with exposure to ozone and humidity changes. And so what's going to happen is that the straps and the nose wire and the foam and all that stuff and the adhesives, those will fail first. So it gets to be a little dicey. And so I think the answer is, if the mask is still fitting well to your face, I personally have no issue with using a mask past its expiration date, especially when you're seeing some expiration dates of only like 2 years. Like I personally don't have much of a risk to do that.
Thank you. Donna would like to know, can you please discuss the table on time to infectious dose for an uninfected person, which tabulates infected/receiver time to infection based on a grid of mask types? How accurate is this table? We know that the 15-minute guideline of exposure to an infected person was historic and made up. What are some realistic estimates? Is there a realistic table available to help us, especially vulnerable folks, to more accurately assess risk in one-way masking situations?
That is a great question. It's a tough one to answer, but let's start at the high level. So I think there's some key technical terms I hit in there. Those heard in there, excuse me. Those are great. So let's kind of parse those apart. So when we talk about infection risk for airborne transmission, we're going to go back to this model that you might hear. It's called the Wells-Riley model. And this was developed by a gentleman by the name of Wells and last name Riley. Wells was working in actually looking at tuberculosis transmission in the 1930s, 40s. In fact, one of the pioneers of using ultraviolet light to disinfect air. That's how they discovered that tuberculosis is airborne. So these two researchers in the 50s, I'm going by memory here. So I think it's like 1950 or 64 that paper comes out, somewhere around there. They took and looked at what happens when people are exposed at different amounts of dose, which is effectively for them, you're looking at a well-mixed box model, and what's the probability you're infected. So the way to think about it is like, if we think about dose response functions, meaning if you get exposed to just a little bit of COVID, for most people, they won't have an active infection and they won't develop anything. For some percentage of those people, they will. And this distribution of this like exposure threshold and the probability of infection, it's called the dose response function. And it's kind of baked into a Wells-Riley model, which is like this theoretical simulation of a space with airborne particles. So it gets that's what gets kind of complicated, is that there's a lot of inputs to that model. And well, the Wells-Riley models are usually used, and I used it in maybe the table. I think you might be referencing one of my videos where I was referencing, I think, P100s versus N95s and kind of using that probability as more of a metric than just like inhaled dose. I think that that model is still fairly accurate, but I will say that the inputs are really well undefined. And those inputs that we have is we have this term called quanta. And aerosol scientists are kind of the worst people because we love to pick tough words that don't mean anything. But what quanta represents is like how much inhaled dose do you have to have like a 68% probability of getting infection. And so how we generate this estimate of quanta is we look at cases that are happening around us. So we might remember that choir case, I think it was in Washington, the Skagit choir case, where there were 60 singers that went in and they sang in the choir for 3 hours. And then like, I think 47 of the 60, which again highlights the dose response function. Not everyone got it. 47 of the 60 people got it. And so they put a pin there, and then they go look, okay, well, there's like a school case, there's like a case here, and they start to fit the curve over time using this data. And so those can be then generated into other models. So Jose Jimenez has a nice COVID calculator. It is not the most user-friendly design, but I think this highlights I probably need to just do a video on this to teach, got to give a background and do it. But there are COVID calculators out there. And they use the Wells-Riley model as the risk calculation. And they do have some inputs, and that's kind of been the tough thing. So we fit these quanta curves, and those quanta curves were fitted prior to vaccination. So what happens is that your dose response function, they call it in the medical word leaky vaccination. I don't know why that exists, but it's leaky vaccination. We kind of all seen that, right? When someone they get infected, they have some immunity over time that wanes. And that waning immunity means that their individual dose response function is changing over time. And so all of ours are dose response. So we get vaccinated, that's going to change our dose response function. We can be exposed a little bit more. We had acquired infection. And so that's changing. And so when we talk about quanta in this distribution, it's actually of the population of people at a time. And so infection, vaccination, I'll change that. We have, like a lot of these haven't been updated. So what's really amazing and sad is that, in 2020, we had 2021, we had a lot of the same information that we day today, even though we have tons of great studies to look at, or tons of great cases that we could be looking at, because COVID is still infecting a lot of people. People are not really doing a lot. You could be studying this in an ethical manner to look at, like, what are the transmission mechanisms? If we had an ACH at this versus this in this building, what was the transmission rate? Like, all of that could give us a ton of data. And surprisingly, we don't have a lot of it. So we have to make a lot of these assumptions about the model. And those are the quanta levels and the activity and the amplification. And so that's kind of how they exist. I think I'm trying to remember the last part of that question, and how can we use it to assess risk? And the answer is, like, what it does is it really matches long-range transmission models. So these use a well-mixed box model. So think of the room I'm in right now. And if I'm emitting particles, what this model assumes is that those particles immediately come out of my mouth and are uniformly distributed in the room. Okay, we all know that it's probably not realistic to what happens if you think about people smoking. It's not like instantly spreads in the space. But we have to make assumptions as engineers, because CFR fluids, flow, and stuff like that is very complex in a space like I'm in. Even though I might be the only individual, if I turn the fan on, it totally changes stuff. And so those Wells-Riley models are good at this long-range transmission and good estimators. But again, it's a population-based estimate. It doesn't count for your own individual dose response. We don't know what it is. The only way to find out is to get, some exposure level and then figure out if you get it, but then it's too late, right? And so they're good first-order estimates. But what they do let you do is to compare different situations. And I think that's, to me, is the power. So you can compare what is at some condition in the dose response function at some point in time, some snapshot of time. What's the difference between wearing an N95 and how many equivalent air changes per hour in a space for like a well-mixed box model would I have to get the equivalent protection? So I've done some numbers like this, and so I think they're kind of interesting. So I can give you some relative numbers. To give you exact risk, it's hard for me. I'd have to know a lot about the situation that you're in, but to give you some relative numbers, wearing a good respirator that's 90% sealed. And so for those who are like super mask nerds, you might hear about the term like fit factor, which you're hearing a lot more. It's great. I see a lot of people talking about fit testing. It's awesome. That would be a fit factor of 10. Usually in occupational settings, they want a fit factor of 100, but this is a fit factor of 10. So it technically allows 10% or 10 times more leakage. If you wear a 90%, filtering respirator in a half air change spruce like this room that I'm in around, let's put 10 people in here. We're going to hang out for an hour. Okay. That number is going to be for 1 hour, us hanging out in this space. It's going to be about 1.6% probability of getting infection. If I put on a respirator in the same space, it drops down to 0.02%, 1.64 to 0.02. And it's about the same as putting in this space, I'm checking my math, about 45 ACH in the space. It's the same thing as donning a mask. So it's kind of crazy. Like, so a mask is equivalent to like an entire couple air, like the air handlers in an entire house, put in this space, just this space. That's how much air circulation we'd have to have, the same as just donning a pretty decently fitting respirator. So respirators are super powerful. They significantly reduce the values. And it's usually like on the order of like orders of magnitude reduction. And so check out Jose Jimenez's calculator. It reminds me I need to do a video on this because I think that there's a lot of people that are interested in understanding that dose response function. And it's not explained by anyone. And I feel like it's kind of complicated and someone's got to do some psychon. So it might have to be me someday or soon. I just need some time. That's all I need. I hope that answered that. It's a complicated question. So it's a good one. That's a really good one. Someone's a real nerd out there. I like it.
The math in that was awesome. I love the 1.6 down to 0.02.
Yeah.
I mean,
it's kind of amazing. And that's a 90%, right? So it's not like we're talking, we're not talking, even a, fit factor of 100 would be 99%. So it's amazing how good respirators are at being a really effective tool. That's why when we first talk about pandemics, like boom, you need to be wearing respirators. We do need to implement clean air long-term because respirators buy us time, right? Respirators are restrictive in a lot of ways. They limit our social interaction. There's impacts to them. And so what we do is we use respirators because they're so powerful, but they have that restriction. We use that to build our built environment to make it safe. So we don't need respirators. It buys us time. And it buys us time to get vaccinations. It buys us time to have better treatments, better understanding of the disease. It gives us so much power. It's just that we kind of wasted it here because we used them and then we're like, oh, somehow we just don't care anymore. But yeah.
Thank you. Molly would like to know, is anyone working on an AI to help people narrow down the best contenders for respirators that will fit their face? Maybe like an online tool?
Yes, there are researchers doing this, and I'm really excited to see some of this work. So there's a group, now I'm blanking on the university. It's in Australia, and I do apologize. It's been a while. I'm going off memory. They are doing an awesome project where they are doing facial scan data of individuals. So they do a pretty detailed facial 3D scan. And then they fit them to a bunch of respirators and find the ones that fit their face really well. And then what they do is they do that across a huge staff at a hospital. So they're collecting facial data plus how well a particular respirator fit that face. And then you use, machine learning models to then figure out, here's the key face features and sizes for these different respirator styles, with the idea that once you train the model, then you can use like an iPhone that has a face scan or other face scan technology to then go back through that database and be like, based on your kind of face dimensions in this model, these are like 3 respirators that will most likely fit you. So there are some great work, and I love that concept because you really do need to marry not just a face scan data that's taking the NIOSH sizes, but really thinking about nose bridge, cheekbones, jawline. All of those are really important in fit testing that aren't captured right now in how we measure. So I'm really excited for that work. I'll have to follow up and see what's happening with it. I know there's some other researchers doing that. So I think that there is a future where you could scan your face and get a mask that is more likely to fit than what we've been doing in the past, where we've been treating N95s as like, you just wear an N95, and it's like, it's like handing out size 7 shoes. Like for some people, they're going to work great. And for other people, they're going to be too small and too big. And we can't stop talking about N95s as it's like this thing. And it's like, we have to think of like shoes, like that's a work boot, and you need to find a work boot that fits your face. And we can't just hand out one work boot size at our Walgreens and say, well, we've solved the pandemic. We gave away some masks, so I'll get off my soapbox there. Sorry.
No, that's very exciting because I know when I bought my flow mask, I was very excited about it, and I bought one for my husband and it didn't fit him even close. And it turns out 10% of people don't fit in a flow mask. So it's hard to go out there and tell people, this is the respirator for you when everyone's face structure is completely different.
Exactly. And that's been my hard, one of the issues that I have with expensive elastomerics is like, they're a great design. I love them, but it's really hard to tell someone go spend $100. Then you can't return it. And you're like, oh, I'm sorry, you wasted $100. And I think I jades people a little bit, like, oh, I had my hopes up with this wonderful mask and I can't wear it. So yeah, it would be helpful to have that technology right now.
Nora would like to know, with the winter condensation that can build up in a mask while you're outside, how frequently should we be changing our masks?
That's a good question. So actually, I was at the European Aerosol Conference last September, presenting stuff on our CPC, the project I'm working on, Open Arrows, and there was actually a great presentation. And I chatted with the individuals, so they were a little uncomfortable with me sharing their work on Twitter and stuff like that. So I just took a picture of it. They did a great study where they looked at, and it was a northern country, Finland, perhaps. I won't say too much, but they actually took and wore masks outdoors to get condensation accumulation, and then they did some fun experiments. They looked at total inward leakage, so how much more particles were coming into the mask. Was the mask stop filtering, and what happened to it? And what they discovered is that the mask still filtered well, and this doesn't surprise me. This matches other data, but they did it on person in a real winter. And what they found is that the filtration still worked great. What they were finding is that was getting harder to breathe in. So what's happening is that condensed water is sitting on the surface of the fabric, blocking the material so no air can go through it. And as that condensation builds up, what you're going to see is that the breathability starts to drop. You're going to see that the leakage through the filter media doesn't change much, but you get more going past it because you're having harder and harder time to breathe. So I think the good answer to this is that if it starts to become difficult to breathe in, or you're feeling a lot of leakage, especially easy to do when it's outside, that cold air coming in is very noticeable, is to think about changing the respirator. And I live in Minnesota. It's cold. Normally, it's actually been a very weird, warm winter, but we did have some ice cold weather last week. And so when I wear a mask outside when I'm like shoveling, because like why I can just I keep my face warm too. So, and so I could experience that same phenomenon. So it's good that the data sets, and there's other data sets that people have looked at wetted masks and their filtration efficiency. And really it kind of drives to pressure drop or breathability. And as it gets wet, it gets harder to breathe in. So that's when I would change it, is if it's getting hard to breathe in or you feel lots of face leakage.
Thank you. Donna would like to know, and this is a similar kind of related question, what is the effect of humidity on the electrostatic layer for the N95's effectiveness?
So yeah, it's a good question. So like liquids, certain liquids, ionic liquids that get to there, if they're in liquid form, it is a problem. However, water vapor condensation is almost as most pure water can get, other than sometimes there's a little seed particle in there. It's very, very pure. And so what you find is that there's not really a loss of electrostatic, especially at humidity, because we're not even dealing with condensation. So in fact, one of the tests for KN95s, NIOSH N95s, and I'm going off of memory, I think the KF94 too, but for surely the NIOSH N95 and KN95 is an elevated temperature and humidity test. So they set the mask in a chamber. It's an elevated temperature and humidity, and it sits in there for a duration of time, and then it gets tested. So they actually have a test as part of this to make sure that someone didn't make a mask that suddenly discharged with exposure to high humidity. And so in general, not an issue. I think we've done some tests at Open Arrows, because I think, and I'll eventually publish, or well, not really publish, but do like a video or something on this, where we're masked all day in the office, pop in and check our mask fit after I've been wearing the mask for like 8 hours in the office, and it's not surprisingly, it still works great. So yeah, breath humidity. I mean, fundamentally, it'll be a big problem if you breathing out caused the mask not work. No one would be wearing those masks, and they wouldn't be used anymore. So, but it's a good question, and I don't think a lot of people have been explained that. So it's a really good question to ask.
Yeah, I feel like we're in the top 1% of mask questions right now. These are some very detailed questions that we're getting, and I love it.
Yeah, bring it. It's great. I love it.
Carrie would like to know about what can be done to improve access to quantitative fit testing.
Ooh.
I learned a lot about which N95 fit me by renting and learning to use a port account, but this is a barrier that most people can't overcome.
Yeah. Well, so the good news is, I mean, that's what OpenAeros is working on right now. So if you go check out openaeros.com, we just publicly kind of announced the Open CPC. What is, again, I'm using acronyms, so I'll be careful here. So a CPC, or a condensation particle counter, it is the heart of a quantitative fit tester. Historically, the reason fit testers are so expensive is the dice inside of it is hard to build. They haven't really focused on manufacturing at a lower cost. It's been really focused on, like, well, you know, people pay $16,000 no matter what for a port account, so who cares? And there's not been a good market incentive for them to reduce cost, because there hasn't been a lot of interest in fit testing until the last kind of maybe couple of years here. And so OpenAeros is working on building an open source version of that heart of that, and then we'll wrap a fit tester around that. So we are hard at work at doing that. We're on the second stage of the NIOSH Fit Test Challenge. We'll know in March where we go, or I think it's March. I got to submit pretty soon for this for this month, and we'll know in next month if we make it to the next round. But we're very passionately interested in doing that. We also believe that quantitative fit testing is probably the most effective mechanism to give feedback. I think everyone that I've fit tested doing quantitative fit testing. So for those that don't know, a quantitative fit test is a direct measurement of when you don a mask. Let me pop one on. Where my stack of masks go? Let's see what do I got in the bag today. We are going to go. Got a Cham pack. These are unfortunately hard to get. Great mask, but I'm really sad that Project N95 closed. Or, you know, it's a real bummer. But this is a great bifold, very breathable. So a quantitative fit tester is exactly the test that you have seen me maybe in my videos where I live stream. What we do is we measure the concentration of particles outside of the mask in the room, and then we put a probe into the mask and measure the concentration of particles inside the mask. And the ratio of the particles outside the mask to inside the mask tells us how good the mask is at filtering. And so a quantitative fit tester can give you the exact value. That mask is giving you 98.7% protection. So that's pretty cool. Now, of course, that protection is at that moment in time. So like we can't take that everywhere. But what you can do is you can find masks for some people. They can get levels that are like 99.8, 99.7, like really high levels with a standard N95. Go to elastomerics, it goes even higher. And what it does is, what I found a lot of people is that, you know, a lot of people don't form the nose wire really well. I think they feel like maybe they don't, I mean, it's not really communicated well, that you have to kind of push it hard onto your nose to get it to really seal. Or if you have a bifold like I have here, you know, you got to flatten the bifold fold with your finger. You know, we don't have pointy noises, so you got to take and squish it. And quantitative fit testing will tell you that. And you can see right away you have a leak. And if you touch right there, boom, you'll see the performance of the mask go way up. You're like, oh, there's my leak. It's in the nose. I just have to do this. And so to me, bringing that to the general public is going to be super important. And in my vision of the future is like, these are at hospitals, these are at fire departments, these are at grocery stores. Like we have blood pressure machine, and you can pop in and check your mask out and do this. And we hope to bring a low cost product to the market. I mean, lower cost, it's going to still be on the order of about $1,500. Maybe with higher volumes, and it is open source. So if other manufacturers can do it way cheaper, good for them. But the idea is like, just make these much more ubiquitous, because I do think that it's the tool of the future. We're not going to stop wearing masks, wildfires, all kinds of stuff. It's going to make sense that we need to have a fitted mask, or wear a mask, excuse me. And the most important thing is the filter media on these masks are really high performing. So it's all about fit now. And that's why we need a tool to do that.
Thank you. Kristen would like to know what your thoughts are on the use of far UV.
That's a good question. So I'll try to summarize this in kind of concisely. So far UV has some extreme potential. It is still very early in the days in terms of its efficacy, and there's a lot of work that still needs to happen. It has some really unique advantages that other technologies out there don't have right now. So in my kind of vision of the future of clean indoor air, we need to make the built environment, the spaces that we spend a lot of time, especially spaces in which we meet some key criteria, that we have long duration at really high occupancy densities, meaning everyone's tightly packed with lots of people. And if we think about where are those spaces, those are schools, those are community congregate care facilities, those are hospitals, because the other piece I didn't mention is that probability of having an infected person is high. At hospitals, people are coming in because they're sick. So you most likely have people that are infected. And there's a lot of other reasons we should be masking in hospitals too that I won't cover in this discussion yet. And so when we think about these scenarios, we have to get the built environment such that the replication number that some people here call like R naught, right? And R naught defines like how fast is a virus spreading, but also it tells you how fast a virus is dying off, right? So we know that we have these spikes of COVID that come back down. So we have an R naught that's greater than 1, it's growing, and then the R naught goes below 1 and the case rate drops. What we have to do is we got to get the exact number is pretty up for debate, but we need a decent amount of our spaces to be in a condition in which the R naught is less than 1. And when you do that, think about a building, a school, 1 kid comes in with COVID, less than 1 kid leaves with COVID. And that's important because when that happens over time, then no kids come in and no kids leave. So how do we get our built environment to R naught 0? So Shelley Miller out of UC Boulder, don't quote me, I'm pretty sure she's out of UC Boulder, has a great paper where they looked at an office space and a bunch of other stuff. And there are only a handful of technologies that are out there that can get the R naught below 1 in like classroom type settings. Those are, you need either masks or UV. And that's the power of UV. Now, there are some side effects to UV that we have to consider. There's indoor air quality impacts. It does generate ozone, a small amount of it. It is mitigatable. There's some tools, there's some techniques. So in my dream world in which we solve the problem is that we go to schools, we ventilate properly and we filter properly. So we're hitting, the ASHRAE ventilation standards. We're hitting the ASHRAE 241 standards, right? We're ventilating the space proportionally. We're filtering the space with the air. So we hit those air changes per hour that we need, or in the case of ASHRAE, it's liters per second per person. We hit those, and then we need something on top of that. So it can either be masks, which have a problem, like we saw with lunch. You got to take them off to eat lunch. Or we can use what we like to call occupant safe whole room UV. And so that's really what I think is the tool to get us to that R naught below 1. And that's why it's really important to work in. It's still early days. The technology is expensive, although there are some lower cost units. It isn't well understood about how much do you need? What is the distribution of light? There is some good evidence about human efficacy, how safe we are to 222 nanometer wavelength specifically, which is that the human body has a couple built-in features to it. We have like a sunscreen for that wavelength, which is really nice. On our body, we have a dead skin layer called the stratum corneum. It's a thick layer of dead skin. And the UV light hits that dead skin and gets entirely absorbed within the dead skin layer. And on our eyes, when we blink, we have a tear film. And that UV light gets absorbed in the tear film. So it never actually hits our body. So when we think about concerns about cancer and stuff like that, it's about UV constantly getting into those cells that are growing and replicating, creating one that replicates wrongly, and we get a cancer. But the nice thing about these short wavelength UV is that it never gets to the living cells. And so we can have pretty high dosages of it. Now, if you're a tiny little virus that's about 1 micron floating in the air, guess what? You don't have that dead skin layer. So the light penetrates into the nucleus that it's floating with, hits that virus either on the spike protein or in the RNA, boom, blows it apart. We've disinfected or deactivated that virus. So that is the dream of 222. So I think it's going to be a very interesting place to watch. We are very invested in helping that. And I think we'll hopefully see more devices. I think Beacon, which is a home product, just launched. Lit Thinking has Visium that just launched. It's the first UL one. There's a few products out there. I think the big issue is that they're just too expensive.
Kind of a follow-up question to that. So in our home area of the Twin Cities, there was a restaurant that installed far UV and pretty broadly advertised, hey, we're safe to eat here because we have far UV light. Would that change an assessment of whether to eat there if you knew that they had far UV, or are we not in a spot yet where that is reliable enough to consider?
It's a tough spot. So I can only speak for myself personally, and that we want to very much host a COVID safer dining experience. I think the data that I'm seeing out of UV is that so we talk about this K value, this disinfection rate, like how many photons does it take to disinfect a virus? And what we're seeing with the UV studies is that the number's going up over time. It started at 3, then we start looking at the data at 6, and then they kind of relook at the data, and that it actually gets killed very quickly. It has this bimodal failure mode, but that first, up to about 90% is a K of 12, which for us, like I don't have a device with me. If I had a device with me, I'd show you what they'd look like. For a device that's like the Beacon that you can buy for about $700 in a space like I'm in today, which is a little too small for that unit, but in theory, that's kind of providing somewhere around like 40 to 50 ACH. So if you think about a dining experience, like, and it's really focused on long range transmission, because short range transmission, there's not enough time for the light to disinfect it. So when you think about dining experiences, it's really stopping the people around you from infecting you. If you're at the table with someone and maybe you don't hang out or spend a lot of time with them, there's still a risk of transmission due to short range transmission, but it stops the other diners from doing it. And all of it's all good, right? This is like the idea. Like, we don't want to wait for one silver bullet. So we want to have a dining experience. We can make indoor dining safe. What do we need to do? We can have good community level testing so that people are sick, stay home. Keeping people that are sick out of the space is the best thing we can do. It's the biggest bang for the buck. If you know you have COVID, stay home. If you have to go walk outside, wear a mat. Just be conscious of what you're doing. The next thing is, we have other layers like filtration and ventilation, which would be in a restaurant. You can add UV on top of it. You stack all those things together, and that's kind of how you can make a safer community, and that's what we have to do. I think that UV will play a role in that. I think that you'll probably see more restaurants with UV over the next 5 years.
Okay, thank you so much.
Yeah.
Megan would like to know, is it okay to leave masks on the dash of your car between wearing? I thought the sun would be helpful, but is it actually harmful?
That's a good question. So the sun and UV exposure to mask is probably not great because it will degrade the plastic material. The car actually turns out, like most glass in cars, has a film on it that stops UV radiation from coming into the car. That's what prevents the plastics from cracking. So most cars have a filter to stop UV radiation. So leaving on the dash, probably okay. I wouldn't worry about it too much. I do think one thing we have to be a little careful about, because we always have this, masking is always complicated than it needs to be, is that in some very hot locations, the indoor temperature of the car can get very hot. And at extreme temperatures, that can damage the N95 filter media. I haven't seen enough data to tell you exactly what that number is, but if you're living in Texas at July and it's 140 in your car, that might be a time to think about, maybe this week I'm going to pull my masks out of that car. I'm not going to leave them in there. I think there is some concern at really high temperatures. We do know that if you go to really, really high temperatures from the N95 decontamination studies, that then they can lose that electrostatic charge at really high temperatures. And it's not clear exactly where that transition point is, and there's not enough data, like, it says all masks or is it just certain brands? So that would be my only caveat about cars, is like really, really hot days in really hot places, you do probably need to be a little careful. Cooler location, leave it on the dash. For the time you're going to wear that mask for a week or something like that, I wouldn't worry about it too much. If it's going to sit there for a year, okay, yeah, probably not a great idea.
Vanessa would like to know, does moisture accumulation inside an Aura N95 while wearing outdoors compromise effectiveness? We kind of talked about that a little bit. Can you dry it out and still expect the static charge to remain?
Yeah. So there's been studies where they did exactly that. They left it out, evaporated off. You can have situations. So this gets like complicated, right? So I'm a big encourager of rewear. It's better for the environment. It reduces your overall cost. You have to be careful of a few things. So if, for instance, you had a ton of like stuff on your face, like could be makeup or other things that then get dissolved in a liquid that then can transfer into the mask and sit on the mask, there can be some slight impacts to that. It's not well understood. It's not well characterized. So there are some risks. Me personally, I would have no issue doing that. I think especially in the context when we're talking about COVID specifically, because COVID respiratory aerosols are much bigger than the test aerosol and a much lower, and we're typically wearing at a much lower flow rate, or we don't really breathe at 85 liters per minute. Although if you're out running, that might be one of the few instances that you do. But in general, our flow rates are lower too. So these masks, like I said, the filter media performs like, especially Auras, like it's really up there. So I personally wouldn't have too much concern about that and let them dry out. Maybe, if it's 100 times, okay, maybe, but I don't think the mask would smell very good after that long.
Dustin would like to know, do you incorporate nose sprays in your layers of mitigation? And is there any good data on any nose sprays in particular?
So this isn't quite my area of expertise. I have looked into it because I saw a lot of things. I don't feel like there's good evidence that they are as effective as people. Again, it's a layer of mitigation. It doesn't hurt people to use it. I don't think so. Me personally, I'm kind of a weirdo in some ways. I don't use a CO2 meter anymore. And I don't use like nasal spray. So I focus on a really good fitting respirator. And the reason for me is like, when you're trying to juggle all these activities and you're trying to do all this stuff and have the regimens get difficult to maintain. So I try to drive for simplicity. Like if I'm going to go to that space and the CO2 is high, I'm probably going to go to that space anyways because I was going to do that activity anyways. So I'm going to wear a well-fitting mask. If I'm going to be on the airplane, even though the CO2 is high, I'm already stuck on the airplane. It's not like I could bail out midway unless I'm on a Boeing. The door might open for me. But so there's a lot of activities. And so like it can be a good mitigation. How effective is it? I don't feel like there's a really good set of data that I've seen about how effective they are, especially against COVID. So I personally don't use them.
Thank you. All right, we are going to get to our last question here. After wearing my mask, I pop it into a UV cleaner. Is it okay to use a UV cleaner to clean my mask? And I wait a day after cleaning it to wear it.
This is a really good question. So I think that the answer is I would probably say don't stick them into UV cleaners. I haven't seen enough data to say that they are effective. And so first let's talk a little bit about the risk. One, when we talk about COVID specifically, the tiny little respiratory aerosols that are floating in, they either get caught in the very outer layer of the mask, which pretty much they don't because that layer is not really that good at filtering. And the melt blown layer, the kind of layer that's doing all the filtering, is in the middle. You actually can't touch it with your fingers. And so all of the aerosols are captured in that middle layer. And if you shine UV light, like again, I don't have any data to support this conclusion or not, but from an engineering assessment, I look at it and say, like, what's the probability that the UV light's actually making it into the layer that has the virus of interest? And it's not. The other thing we have to think about is like, one, COVID doesn't really transmit very well as a fomite. Now, there is some studies that came out where they were looking at nurses who are more likely to pick their nose, and they did see a statistically significant increase in people that were nose pickers having COVID. But in the broad spectrum, the CDC estimated it was like 1 in 10,000 cases were by fomite transmission. And I think that that's, you know, if you're not rubbing wet slobby noses on each other or kissing people, like that kind of transmission, we're thinking about normal distance type stuff where you were doing that. Like the mechanism is airborne transmission, and it's really hard to get a dose enough on your finger. So my monitor turned off there. Dose enough on your finger to then transmit it into your nose to get the infectious dose to get it. So like in terms of me, fomite transmission for COVID and other diseases aren't really something I worry about. When we talk about bacteria and stuff like that, so you're kind of at this homeostasis with bacteria all the time. Your face and your body is covered in bacteria, and it always is, and it's all inside of you. We're this weird, complex bioorganism that has not just our DNA, but all these bacteria. We've learned a lot about gut health and impacts of COVID on gut health and all these kind of weird side effects. So that bacteria is already on your face. You already have tons of it on your exposure to your face. It's multiplying. It touches the mask. It lives on them. It transfers to the mask, just like it transfers to my clothing and other things. And so it's more about hygiene in terms of appearance or smell, and less about the impacts of like, are you going to get a raging infection? Now, there can be situations, of course, with people with dermatitis, inflammation. There's lots of other considerations in that space, but in terms of like transmission of COVID, I'm really not worried about them coming through the mask. And I personally do not disinfect my mask. I do let them sit out sometimes for a day or two. And, you know, knock on wood, I keep my record going here. So I think the data kind of shows that fomite transmission isn't something I'd be worried about for COVID in the situations we're talking about here specifically.
Thank you so much. All right, so we are kind of running out of time here, but I have given all of our other speakers the opportunity to soapbox on anything that they'd like to at the end. So if there's anything else you'd like to touch on, the floor is yours.
That's a good time. So I think one, thank you for everyone for masking. Thanks for coming out and chatting mask. As always, if you want to get in touch with me, hit me up on YouTube or Twitter. Hit me with questions. I try my best to answer those in a periodic basis. It's kind of been hard for me because we've got a lot of projects going on, but I do try to spend a day, jump in there and try to answer questions. So hit me up if you have like really, you know, some specific questions. I know there's always a lot of questions about mask recommendations. So I did just do a 2024 video with some of my top picks focusing on good breathable masks because I think that drives comfort. Check that out. I do still have a kids video, and in that kid video is a link to a spreadsheet that I do update every time I see a mask and people give me feedback about how it fits their kids. I kind of tweak the numbers a little bit. So if you're looking for recommendations, check that out. I think the one thing we didn't talk a little bit about is fit testing. And I think that for all the maskers here that are still kind of really into this, so thank you all, fit testing is really important. There's a few mechanisms that you can get to it. Now I'm going to plug, I have no economic relationship or anything like Fit Test for All. This is a low cost qualitative fit tester. It's a little Bittrex spray. They have a whole test procedure. It's a really good, nice way to learn about how well the masks that you might have fit better relative to each other. it's kind of a little hard unless you have experience with this to figure out, like, am I at a qualitative 100 fit factor test? It's a little hard to figure that out, but it is a nice tool to figure out which mask fits you the best. $39.99. I think this is like a really great kind of like general public solution. So check these out. They're a nice way to figure out how well your respirator works. If you want to be a super nerd, you can do quantitative fit testing in your area typically. What you want to look up is for words like industrial hygiene, or if you search just quantitative fit testing, there are services. They go to hospitals and do stuff. You can usually schedule a time to go to their facility and they will fit test you on a respirator. You usually have to bring them. If you're a super nerd or if you want the most protection, can't recommend that enough. I'm working hard to bring that to y'all, but it'll take time. In the meantime, those are great options. They're also, check out Twitter. There's a lot of people buying used port accounts. They work great for, they might be 15 years old and they still work. If you can't do any of the above, stand in front of a mirror and you can do a few things. One, make sure the nose wire is well seated across your nose. If you wear and I'll get out my demonstration mask, let's say you like a bifold. Again, some people only fit bifold. So I hear a lot of talk about, oh, I don't like bifolds because they don't fit anyone. Well, for 10% of the, like in my experience, a percentage of the population only fit in bifolds. So we have to be careful about talking about masks. Say, oh, those masks don't fit anybody, because they do fit some people and they may never try them. But if you like a bifold ear loop like this, there's the crease here. So when we think about how can we do better about fit testing, so flatten that with your nose, or your finger and your thumb, flatten it out, and then you can kind of fold it around your finger to give a nice radius to that. So think about when we wear a mask is to really focus on nose wire is usually the most leaky spot. So really work that in and make sure that you don't feel any cold air coming in and out of here. Make sure that it's well sealed around the mask. If the ear loops are not tight enough, you can either tie a knot in them to tighten them up, or you can buy cord locks that are available on Amazon. I think some craft stores sell them, and you can basically put a little toggle on this and adjust them. So really good making sure with ear loop mask that the tension on the ear loop is good. So thinking about doing these kind of simple things can really up your mask game. If you want to go to the next level, think about purchasing the sorry, I mix this up all the time. The qualitative fit tester, this Bittrex solution stuff, they're for sale. If you want to go to the next level, look at quantitative fit testing, but you'll benefit all along the way. And like I said, respirators are amazingly powerful tools that can make a lot of spaces that are typically not safe, much, much, much safer. And so I can't say enough, wear a good mask, wear it often, and you'll have, you really improve the probability of avoiding infection.
One of our chat feed people wanted to know if you could say again the name of the fit test gadget that you're holding and where to get it.
Sure. It's Fit Test for All. Let's see if I can get it in the camera. It's hashtag focus. It's hashtag Fit Test for All. They have a website. It's also on Twitter. They're on Twitter. And they have a great little product they're selling. They come and go, so you have to sometimes sign up for like the next lot. So you like builds a lot, ships, builds a lot, ships. So sometimes you might get it right away. I did just check earlier today on their website, and they did have some available. So check those out. It's a cool. I will warn you though, if the mask fails, you will very quickly learn about the taste of Bittrex in your mouth. I'm just looking up Fit Test for All.
Yeah, is that the number 4 or the word 4?
Yeah, I'm trying to find it too. Now that I have to actually look at for myself, I'm struggling. On this, they have written the number 4. I found it, and I will put it into the chat right now. And of course, I looked today, and there was some, and it is sold out. So maybe just today, with all y'all chatting away here, that happened. I'm going to go ahead and drop it in the chat right now. You can sign up for a waiting list. Oh, maybe someone beat me there to it. Oh, everyone's throwing it in there. Hey, look at that. Awesome. Thank you. Yeah, so sign up for that waiting list. It's a great way. Now, if you want something, you want to do a qualitative fit tester a little earlier, because those are now sold out, you can buy them. Gerson makes one. Moldex makes one. There's a few other companies that sell these a little bit more expensive. They're going to be about $125. You get this hood, you get all the things. Just, that's another option too. If you can afford the extra, $60-70 and you want it today, those are another option too. Again, they're the first way to kind of introduce good quality fit testing to people.
Great. Thank you so much. I'm I've had several people DM me asking if we can have another session with you. So if you ever are available to come back, it sounds like a ton of people would love to do another expert session with you.
Anytime. And if you want to run a little longer, we can run a little longer. So if there are people that have questions, I kind of booked to 7:15. So I mean, I know y'all been on this call for a long time. So
I was going to say I have a hard cutoff at 7 Central, but certainly I've dropped your YouTube channel in the chat a few times. I can drop your Twitter as well, or your X, I guess, at MaskNerd.
Yes.
And then are you on Threads?
I am not on Threads. The Instagram world, I'm such a nerdy numbers and text guy that the visual world is a disconcerting place for me. I tried the Instagram. I'm just like, I can't make pretty pictures. My pictures, I tried my best for a while. But you can hit me up on X, Mastodon, Blue Sky, also on my YouTube. If you have a comment or a question on the videos, just type it in there. I usually go through and answer them once a week. So just hit me up and we'll do our best to answer those in a timely manner.
Perfect. All right. Thank you so much. Really appreciate all of the really thoughtful questions that everyone has brought. It's really great to be in community with other people who care about this topic. So thank you all for being here and continuing to educate yourselves, take things seriously, share information with your friends and family. We really appreciate it. We really appreciate you. If you want to connect with us, we are on Instagram, we are on Twitter, we're on Threads, we are on Facebook. We have a Facebook group called Mask With Us, and you are more than welcome to email us at MaskTogetherAmerica@gmail.com if you have any further interest in getting involved with our organization. So thank you so much for participating, and I hope you all have a wonderful rest of your night.
Thank you. Thank you very much.
When we work together, we can accomplish